trained. And so if you need to answer your phone or do things, just be conscious of the fact that the mics are very good at picking things up. And if you do need to go on your phone and you're on the screen, please could you turn your camera off to do that, so we don't have those things. We've got apologies from board members, Sam Crowe, who's Director of Public Health for Dorset and BCP Councils, Keith Falf, who's the Pro-Vice Chancellor for Education and Quality at Bournemouth University. And I had apologies from you as well, Ben, but I can see you staring at me, so you're obviously here. So I will remove that one. Thank you. And then, is that Charlotte there? It is. Good morning, Charlotte. So a big welcome to you as the VCS representative on our board. You've taken over from Zoe, and you've been appointed as the new chair of governance of the governance board for the Dorset VCS assembly. So welcome to our first meeting. It's great to see you. I think we have a couple of people that need to pop out partway through the meeting. So I know Rachel is one of them, and Nick is the other one. Right, so are there any declarations of interest? Okay, if anything comes up as we're going through, please declare it. And so what I'd like to do now is to work through the minutes of the last meeting, which was on the 5th of September. So if we start with, I'll turn the pages. So we can start with page 2, because page 1 is just the attendees. Page 2, page 3, page 4, page 5, 6, 7, 8, 9 and 10. So we'll take those as an accurate record of the meeting. Good morning. Morning. Then let's go to the action log, and you'll see on the action log that all of the actions are closed, even on the 2025. So that's quite ahead of its time. Paul, where is Paul? He's not here. Finishing for me, that's fine. Yeah, so well done. And Dean, I think you're going to give us an update on 24126, which is the no criteria to reside one that we did at the last meeting at Church and Paul.
Yeah, because I want to give an update, because actually it's not closed because we haven't got the data in the performance report yet. Myself and Gillian, with Betty, have been working through what additional data. You'll see when we get to the winter plan, there is a set of monitoring that we have agreed across the system of what needs to be monitored to get back to the criteria to reside plan we've got. But what we asked we agreed at the last board meeting, some additional metrics that will be monitored within the local authority to understand where individuals are through the assessment process. So we've got the start of that, we've been looking at time to assign a social worker to it, but I've offered some insights from how we've monitored PTL, the patient tracking list for cancer patients, so that we track right through to the end process, so that we know that it's been completed and when it's been completed. And I've offered that as a way potentially of looking at it for those individuals that are going through that assessment process. So we track not just the allocation of social worker, but the process right through to completion of the assessment process.
And is that across both councils that's been done?
At the moment, it's just for BCP, because that was but once we've got it in place, then we can transfer it over to Dorset Council as well.
So when do you think that will be in place then? Because I think what we probably need to do here is just to update the timescale on there.
So I'd expect
this is about when it starts.
Certainly by the time of the next meeting, we need it in before the winter starts, so we need it in this month.
Okay, Matthew.
Thank you, Dean. That sounds very positive, and I know that there's an awful lot of joint working involving local authority and health colleagues in this space. I think it is very important that it's done consistently across the RCS for both local authority areas. Could I just check that this work will include mental as well as physical health. Again, I'm aware there's a lot of very positive work going on to look at the numbers and delays in mental health, but I'm just advocating parity between the two areas.
Yeah, absolutely. We'll do that.
Yeah.
Thank you.
Okay, anything more on that? Okay, so if not, let's move on to the slot that we normally have for board stories, and today it is on enhanced productivity and value for money, and it's a deep dive into those things. And of course, I'm assuming what comes out of here will help our discussions later on when we start thinking about some of the other things on the agenda, such as the finance, etc. Who have we got for this? So we've got Sue. Welcome, Sue. Yeah, I will do. And Paul Wyman, is it?
Yeah.
Welcome, Paul. Okay, so over to you first, Rob.
Yeah, thanks. So just before I hand over to Sue and Paul, the presentation they're going to go through is focusing on productivity, but the agenda items is productivity and value for money. So we have an awful lot of stuff that goes on value for money that's not going to be included in this presentation, including value for money audits, SFIs around what you get right in the quotes, etc., through procurement routes. That's always part of it. But for this presentation, we're focusing on the services and the value for money that you get out of the productivity increases. So, the definition of productivity, sort of a blunt definition, is if you can do more with the same amount of resource or more with less, as long as you're not doing less work with more resource, then you're increasing your value for money naturally through that as well. So that's why we've taken this, because we know that in the Dorset system, productivity is one of the big issues that we're trying to address.
And Rob, just before we get started, so when we're talking about productivity in this context, are we talking about NHS productivity, or are we looking broader across health and care?
Shall we go through, because Sue will address that kind of, because there is a relatively narrow definition.
Yes, there is, even within health.
Even within health. Yeah. So we bring that out in the presentation.
That's fine.
So
Thank you.
Could we hand over to Sue? Take us through that.
Morning, everyone.
Morning.
So I'll go straight into the slides then. So just to start off, reminder, of course, of the four purposes of ICSs, one of which is increasing productivity and value for money, as Rob has just described. So just by way of a bit of context, pre-COVID, the NHS delivered productivity at a faster pace than the rest of the public sector, and that includes the wider economy. 23-24 data, and this is just for the acute sector, tells us that productivity was around 15% lower than it was pre-pandemic. However, it is, I think, really important to note that actually expenditure had been rising pre-pandemic, and the rate of growth hadn't been keeping up. So the Lord Darcy report from September of this year says there is an urgent need to boost productivity. And the pink box on this slide is really important and connected to your question there, Jenny, because from an NHS perspective, when we say productivity, in basic terms, it means we're comparing inputs and outputs. So it looks at money spent and workforce grown versus activity done. So it is a very narrow view for the NHS. So what that means is that something can't just be more efficient. You have to replace the space created by inefficiency with more activity to create that productivity. So to give a real example, a theatre starts on time, turnaround times in between patients are reduced. So rather than finishing early, you would replace that time with more patients, and that increases your productivity. So what does this mean for the ICB, for the ICS? So these are all areas on here. So the 7 boxes on this slide are all areas where we have a role, and I'll just draw out a few examples just to kind of try and bring that to life a little bit. So we have Southwarks House, which we'll come on to in a little bit more detail in a moment. And that's actually just kind of having your mind as you're watching the video that I'll come on to, that actually it does all of these things right across all of those 7 components. The work that we're doing at the moment with our strategic partner Newton, and there's a bit of information in your appendices about that as well, is currently in the strategic planning phase. We've got some work, a project underway around targeted lung health checks for cancer. So that's an example of the prevention and early intervention. We've got a couple of slides a little bit later on for workforce and digital, so we'll cover those there. And just to say as well, I spent a day at DCH, so Dorset County Hospital, yesterday, which was a really, really good experience, and saw lots of great examples of continuous improvement, and this is in the theatres space in particular. And one example is a pilot that they're doing around, and this is in the orthopaedics department, around a joint school. So this is about getting people as ready as they can be, optimised for their surgery ahead of time in order to improve their outcomes following surgery. And actually, there are even more opportunities in that space in particular for continuous improvement there. So I'll just go into our we've got a video for Southwarks House.
We're delighted to have opened our newly refurbished outpatient assessment centre at Southwarks House. We originally started using this council office building as a temporary arrangement in 2021, as we didn't have enough space in the main hospital to see the additional patients who were waiting for appointments during the COVID pandemic. The success of our temporary facility allowed us to secure a 20-year lease for the building, along with more than £14 million from NHS funding. We have refurbished 2 floors into new dedicated clinical space, along with another 2 administrative floors. We now have multiple extra clinic and treatment rooms with much needed diagnostic equipment, including ultrasound and X-ray machines. There is a central hub where clinicians across different specialties can work together to solve problems, and patients can be signposted to the specific services they require that day. It also supports a one-stop approach where patients can see one or more of the professionals they need at the same place and time. Our volunteers will be on hand to assist with the smooth running of the clinics. Live Well Dorset and Active Dorset will also be offering health and wellbeing advice to patients. We're based in Dorchester Town Centre, right next to the library, and only a short walking distance from the shops, so patients and visitors can enjoy some of what the High Street has to offer before or after their visit. Most importantly, it will allow us to reduce waiting times for outpatient and diagnostic appointments and make sure patients receive the right care and treatment more quickly.
I'm so excited about this project here in Dorchester. I first visited Southwarks House when it was a temporary facility for outpatients, and actually the concept has gone from strength to strength. So when we had the opportunity to invest in this facility as a permanent facility for patients, I was very, very keen to support this. This outpatient and assessment facility is going to help patients with speedier diagnostic tests and outpatient consultations, and the beauty of this facility is it's in the heart of the town, so it's convenient to patients, it's a modern facility, and it actually keeps patients' care out of the acute hospital setting and in their community where they're much more comfortable. And I'm hoping that this concept will grow and we'll see more of these facilities in town centres and closer to patients' homes in the future.
So a great example, and during my day with DCH yesterday, it was really good to be able to walk around Southwarks House as well. And just talking to the staff, they've got even more great ideas to make what is already a product, an innovative solution, even better. So the way things are booked and pre-op assessment, etc. So just thinking back to that continuous improvement phase, there's really good ideas there from staff as well. So that was really good to have that opportunity yesterday. So I'll just go into performance. Just going back to that earlier definition for productivity for the NHS, we get some data from NHS England, and that tells us how we compare as a system with our ICB peers. So that's across our region and also nationally. And a couple of take-home points I draw out of this slide are just to say the national average from 23-24 was 2% implied productivity. For the South West, that was 4.1, so higher, but our Dorset system 1.8, so clearly lower. And actually, the Dorset system is the second lowest in the South West. So whilst that doesn't sound great, actually what that means is we've got lots of opportunity to improve. This is the dashboard that NHS England provides, and again, this only measures acute trusts. So we can drill down for elective care, outpatients, non-elective and A&E attendances. We don't get some other views that actually we would like to have. So for example, maternity, virtual wards, advice and guidance. But from this data, what we want to see is an improvement in that implied productivity. And so we reach, or I would say, be better than the Southwest average. And what we also want to do is stay static or reduce for outpatient follow-ups, non-elective and A&E attendances. So this is what the dashboard looks like. This slide is the system view. So again, it's just our two acutes. And as referenced, we are showing a 1.8% growth. However, this figure does mask some things that we probably don't want to see. So all activity, so we want more elective activity, for example, and first outpatient appointments, but we don't want more non-elective activity. So all activity contributes, but not all of it adds value, and that's just a lack of sophistication in the current model. This is the DCH view. So a couple of positives. So positive is that we're increased in outpatient first appointments, and that is 4.1% above the regional average, which is clearly really good. Also a positive is elective. It has increased, but that's lower than the regional average. But there has also been significant increases in unplanned, so for non-elective activity and A&E attendances. This is the same slide for UHD. So again, similarly, good increase in first outpatient appointments and just above the Southwest average. So a good that's a good indicator. And also good increase in the elective, but that's lower than the Southwest average. So just to give you a sense of where we're kind of benchmarking there. And another example of what we don't want to see is an increase in outpatient follow-ups, just as an example. So apart from pay, which is our biggest driver, there are three non-pay drivers just shown here. So one is non-pay for procurement, non-pay operational, and then the third one is for depreciation. Just a kind of final dashboard slide. This is the system productivity against the 1920 baseline. So pre-COVID, we deteriorated in the Dorset system by 15.7%. So remember I referenced earlier the circa 15% rates for national deterioration. So it's similar, and which is also similar to the Southwest, which is 14.7%. And across our providers, that breaks down as UHD 16.5 and DCH 12.2. So the so what bit, what can we do next? NHS England also publish productivity metrics, and we're benchmarked for length of stay, no criteria to reside, and theatre utilisation. And I just reiterate that point before around how we become more productive. So it's more activity at the same or less cost. or it's the same activity at reduced cost. So these are all the opportunities that we've got to improve. And I'll just come on to a couple of specific examples. So for workforce, all of the examples on this slide, apart from the system vacancy control panel, are provider led with ICB input. Just to note on the system vacancy control panel, following a recent NHS audit, it's been highlighted as that actually our processes have there's good rigor in our processes, so we've got some really positive feedback on that. And I'm just going to pass over to Paul for the digital slide.
So in Dorset, we've for the past 5 years we've been running some automation systems that based for manufacturers' products, and to date we've saved over 30,000 hours of wasted repetitive work for users and giving them back time to be more productive, let's say. The majority of these processes are back-end ICB admin processes, and based on the projects, other projects around the country, we could be looking to save in excess of 300,000 hours a year. So we're starting to focus more on clinical-based or patient-based automations. As an example, some of the stuff we're doing at the moment, we're running a friends and family survey. So the friends and family team in DCH, for example, are currently, they should be processing SMS messages to outpatients and A&E staff, patients, asking for satisfaction surveys from them. That system's actually broken at the moment. The company they use is not available to send the messages, so they actually have to process all of these by hand. So they're handing out paper, staff are then collecting the paper, bringing them back in, putting them into a spreadsheet, which is then turned into a dashboard. So they're being very efficient, but there's limits to it. We've developed an automation which we can take all of that work away from them. Presently, there's 165,000 potential patients they could be questioning. They're getting 47,000 responses back, which is pretty incredible, which is up to 575 a day. That's 3 staff doing that, and we can do that with robots and automated systems. Another example would be e-fin invoice systems for Dorset Healthcare. They're currently processing 45,000 invoices a year. It's invoice matching, so when an invoice comes into the system, it's then matched against the e-fin system. This is done by a person. It takes 10 minutes per invoice, so there's a significant number of staff doing that. I don't actually know how many at the moment, but we'll find out. Care track reporting for the PHC CHC team. They have several people performing reporting on patient treatments and care track packages. That's taking each person 3 hours a day. We can automate that, which we're working on at the moment. And we've got another one for the primary care team, which is the leadership self-assessment forms, which is I think a single form with 165 questions being sent out to everyone to complete. That data is then gathered, placed into spreadsheets, assessed as to whether they passed or failed to that, and information is passed back to them about how to learn how to do things in a more accurate way. And we're about to go live with that, hopefully, and that will be fully automated from end to end. So we won't need any human interaction at all. Thank you.
Thanks, Paul. And yeah, just being with spent some time with the booking teams at DCH yesterday as well, and saw how they got the opportunity by using digital to contact patients to fill slots at short notice that had been cancelled by other patients. And actually, if they've not used that, then those slots would not have been filled. So that was just it was good to see that in action yesterday. So really great example from the clinical services review of separating out planned and unplanned care. This is for UHD across the Poole and Bournemouth sites. Yeah, just fantastic example of being able to increase productivity and on a sustainable footing as well. And just thinking back to that other slide that had all the boxes on it, another example of of doing everything on that box within that work overall. Again, spoke about the theatre reconfiguration, and again referring back to my visit from yesterday, it was really good to see how that's kind of coming to life. So the additional theatre capacity, the day surgery unit at Weymouth, Theatre 8, the new procedure room that we saw on the video at Southwarks House, as well as a way of increasing activity at less cost, and of course supporting reducing our waiting lists as well. So just a final slide before we kind of go into discussion and Q&A, just thinking about how we track how we're doing our progress against productivity. We have our integrated performance report, which we would actually like to include a wider range of indicators, and that will be part of our next steps and on the work we do now. And the NHS England dashboards that I've showed you, whilst only currently quite high level and only our acute trusts, they are helpful to help us to signal where we need to pay our attention and do more. So I'll just pause there and hand over for the discussion, Jenny. Thank you.
Thanks very much, Sue. What would be helpful in terms of the discussion? So you've covered the what, so what. Would the focus on the what next? How do you want us to steer the discussion? That would be helpful.
So where there was a discussion earlier this week at the system, during the system conversation, and having an increased focus on productivity in this space, we've got some thoughts on things we want to do next. So I suppose from our point of view, a discussion centred around that would be helpful, because that will help us in immediate next steps that we will take.
Okay.
I think also to say, when we get into the medium-term financial plan discussion as well, that was one of the key themes that came out of that. So there will be kind of that opportunity as well to build that into the medium-term financial plan that we are developing, and the discussion later on. So
okay, so if I take Forbes and then Siobhan.
I think Siobhan was before me, Jenny, so I'll defer to
Siobhan.
Hi, hello everyone, morning. Sorry I'm not in the room, but just from a sort of elective perspective, because I'm the elective lead and chair the elective group in Dorset. I mean, I suppose where we are, I think it's really helpful that we've now got quite a sort of finite set of measures to help drive our productivity. I think it's really important that we look forward, and that actually also, as we're aware, there's on model system, there's not only these productivity metrics, there's also a section now which is really driven around improvement. And regionally, we're developing learning and innovation networks. And actually, as part of that, there's quite an elective programme around the Southwest that's being developed to help us drive improvement. And I think for Dorset, we were talking at our last elective group about how we will use the infrastructure we've got on elective to drive improvement aligned to what's happening across the Southwest, which I think will be really helpful. I also think that across those set of slides, there's a lot of the clinicians out across our patch are working incredibly hard through what has probably been quite a difficult time to really drive productivity, and they really care about it. And I think you could see that from the video that we had at Southwarks House. So I think we're in a better position. I think we're very focused. I think we've got a lot to do. And I also am aware there's a quantum of money that actually we can save the system by getting ourselves in a more productive space than we probably currently are. I suppose there's a couple of caveats. One is, as you look forward on the medium-term financial plan, and us having a sort of plan with a vision and actually really clear about what we're doing year on year, next year the changes, and then the changes the following year at DCH potentially do impact on productivity at that point in time. The good news is, as you look then to year 3, 4 and 5, Dorset will be in quite an incredible position in terms of the way we work in hospitals and productivity. So it's tricky, and I'm just being really open about the fact that over the next 2 years, there's a lot of transformation going on with all our teams that lead us into a much, much better space. And then my final point is, we mentioned digital automation. I think, you know, the electronic health record is really important in Dorset, and it will create a very different, transformed way of working for clinicians and teams in Dorset across interfaces. And that is just so important to us as we look forward.
Thank you, Siobhan. Forbes and then Matthew.
Yeah, thank you. So sorry I didn't see all of the presentation, but it's a simple question really about centralisation of outpatient appointments. So I fully support the concept of Southwalks House, and I hear this expression. It's great, get closer to home. That's fine if you live in Dorchester. If you don't live in Dorchester, which a large number of our community don't, with all the issues that are around transport, I fear that in order to support Southwalks House and the centralisation of services, there's a reduction in existing services, perhaps in community hospitals. And I just wondered if that was the reality, because anecdotally, that's what I'm being told. And also to make sure we're utilising our existing community estate.
Shall I take a couple of questions and then come back? Would that be helpful? And I don't know if you can answer that or somebody else, but let me bring in Matthew and then Dan.
So just on that theme, Forbes, kind of my own view is that outpatient presence in community hospitals is really important. And we've talked, Siobhan, haven't we, about the importance of kind of having that view in the elective work that we do across the system. So I think local provision of clinics needs to be part of our strategy and approach. And we also need, the integrated neighbourhood teamwork won't drive all of it, but we need to be looking at that as part of our integrated neighbourhood teamwork as well. I suppose the point I wanted to make about this is, thanks for a great presentation, really good way to begin the morning. Like Siobhan, I think this really shows the energy and intention and focus of our clinical and other staff who are driving this. For the board, I think, and this links back to our workshop that we had earlier in the week about the medium-term financial plan. I think we need to challenge ourselves about how essentially sort of how we can get even greater clarity, how we can see the wood for the trees here, because there's a lot of information here, and where we need to get to is, what is our opportunity for Dorset? What's really the ambition? And sort of comparing this year to last year in terms of productivity is interesting and gives some signposts, but it doesn't answer that question, because kind of all of that's about sort of relative positioning, as indeed really is the comparison back to the 1920 baseline year. So earlier in the week, I thought we had a very good conversation about having an ambition to get to upper quartile position on essentially on these measures. And I think that what we need to do as a system is to become clearer about that ambition and actually what that means in terms of financial opportunity, and ultimately relating that back to the difference that this makes for patients and therefore the choices that we've got in the system. So I think we need to challenge ourselves to get a kind of harder edged view about really where we are in terms of performance and where we could go. And at the heart of that will be understanding absolute costs. So it's the absolute cost of our hospital services, the sort of weighted activity unit measures, the WELL measures, etc. I also think as a board, and I think this is a slightly different task, and we shouldn't blur the two. I think as a board we should be saying this isn't good enough as a picture of productivity in our system, and we need to be looking at productivity across the whole system. And one of the ways into that is probably for us to begin replicating some of the measures that showed up in the Darcy investigation around actually where are we spending our money, how much of it is spent in acute care, how much of it is spent in primary care. For us, actually, how much of it's been spent with ECSE, etc. We need to understand that now, and we need to have that hardwired into our financial plans. So we've got our statement of ambition about how we want that to change over time. So that those would be my comments.
Just before I bring Dan and then Matt in, can I take the chair's privilege and just add to the comments that Matthew just made, because the NHS productivity is focused on hospitals, it's focused on the acute hospitals, it doesn't go broader than that. So, and I know it's when I've been part of national meetings, we've tried to challenge that, tried to get into community mental health, etc. But I wonder if there's something we can be doing as a system to try and come up with some of our own productivity measures to try and influence that broader agenda. So if you add that as well as part of your response to that, and then I've got Dan and Matt.
Observations rather than kind of questions, but thank you for the presentation. I had a similar point to Forbes about rurality and kind of I was just struck by use the town centre, use the high street, and kind of just made me think about the population of Dorset. So just worth, if there's any reflections on how do you tackle urban and rural county. I've never seen those dashboards before, and it just made me think it was really worth thinking about how we use them at PPC, the performance committee, as well as in the integrated performance report, because I don't think, maybe we have seen them before, but I don't recall them, and they're really useful. And then the national dashboards on the acutes are really helpful, but it's all about kind of what I call flow measures around theatre utilisation and that stuff. It made me go to cost prevention, to cost avoidance through prevention and kind of earlier interventions in healthcare. And I just wondered what we were thinking about. How do we, in effect, divert people from acute settings by preventing preventing issues earlier? That's a really complicated thing, right? But I'd just be interested to explore that a little bit. Thank you.
Thanks, Jenny. It was just to build on the points that Matthew had made and yourself really in that space. How do we ensure the plans in the NHS system to save money don't negatively impact on other parts of the system? We've got this comment earlier on about underinvestment in capital, but also social care. Underinvestment is an interesting term. One might say lack of funding is a better description of that. We've got perhaps some live examples at the moment where the Integrated Care Board kind of continuing healthcare savings are negatively impacting on our social care budgets and therefore approach. So it's whether we can commit to that, looking at the expenditure jointly and agree an approach that looks at a sort of better gain better value for all funders in that space. I'd also add to Matthew's challenge, I think we need to be slightly more ambitious in some of this. I'm quite interested, great to hear about automation of invoicing payments. We've been doing that for 15 years in local government. Feels like it's a bit of catch up being played, but good to see it happening. But where's a little bit more ambition in terms of some of the productivity gains that could come from that. And I suppose the final point for me is, how does this increased activity square off with our prevention agenda? I think the point that you're making a little bit down. We know we've got to do some more activity to get through the backlog and the waiting list and everything else, but how do we get ahead of that curve by also investing in that preventative piece, so that all we're doing is not making the hamster wheel go faster and faster, which is my constant play. And that prevention agenda has got to be a key part of this conversation ultimately.
I know you want to come in, but there is a theme there also around the government's left shift, isn't there, of what we're drafting. So
yeah, there is. And I think first of all, there's something about us understanding really deeply what drives productivity. And I'm not sure we fully understand the connections between digital capital estate and workforce skills and how that all manifests itself. So I think we need to understand that first before we start getting into what we think our productivity measures should be. Then we make sure that the actions we're taking are triangulated properly. And even though in the new hospitals programme, the NHS in Dorset has had a lot of investment, we need to remember that that investment has been additional capacity, not refurbishing a lot of our existing estate, which is really old and does not lend itself to highly productive services. So we need to think about how we use our infrastructure strategy properly to address some of that, while there's a national conversation happening about how we address the underinvestment in capital in the NHS overall, because the backlog currently sits at somewhere around £6.5 billion, I think, for hospitals, and a similar backlog maintenance issue in care. And at present, there is no solution to that. I think there's something about absolutely agree with what Forbes said around making sure we maintain community access to outpatients. I think we need to be really sophisticated about how we do that. Historically in Dorset, the take-up of community outpatients has not been fantastic, and we've lost lots of capacity as a result, because whilst people want to be treated close to where they live, they also want to be treated close to where they work if it's during the day, so they don't have to take days off for work. So we need to be a bit more sophisticated in how we plan that. The whole point of Southwarks and Beals is not to centralise all of our outpatient services. It is to provide a one-stop shop so that people who are coming into the main areas don't have to come several times for different appointments when transport infrastructure isn't good and affordability isn't either. So we need to try and find a balance between all of those. I think that conversation about how we get the balance between increasing productivity as well as moving more into the prevention agenda is all described in the leftward shift of the Tricia Hewitt review. And I think a big part of our medium-term plan needs to focus on exactly that. So that will come through the integrated neighbourhood teams, but there's more work to do on understanding how we increase productivity, get value for money, at the same time get into the prevention space of assessing and supporting people much further upstream, so that we're not seeing as them using high cost services going forward as their condition progresses. And I think we've still got work to do in that space to understand how we get into that conversation, but also how we shape our services around it, and how all of our care models take into account secondary prevention. And we as an ICB work more closely with our local authority colleagues on the primary prevention space, because there's a lot that we can do in that space, if not about government legislation. But the important thing for our health services is that when we start to transform our care models, that secondary prevention is a really big part of what we do, and it's not just responding to ill health.
Steve and Paul, I don't know if you wanted to add anything more.
Just a couple of examples that came to mind just listening to that discussion. One is some work that we're doing around gynecology at the moment, under a kind of commissioning for sustainability umbrella. So this is about working with the whole system, all end to end, right from patient self-care, GP advice, through to follow up from acute, on how we remodel and reshape and redesign our services, and that kind of shift left in terms of the activity being closer to home. What are the things that are currently being done in hospital that could be done in a more specialised community service, and what's currently being done that could be done in a general practice, for example, and what that means for workforce and infrastructure and all those kind of things. So that was a real current example. And we're getting our clinical and managerial colleagues together in the next couple of months to kind of look at that in more detail. And the other one, again, was a real example from the great day I spent with DCH yesterday around how actually our estate, so you kind of look across all specialties and think, oh, there's something great happening over here, why can't you replicate it for this specialty over here? Because actually the estate is different. So whilst you might want to bring all your patients in at the same time in the morning, so that consultants don't have to be going out and stay to do further assessments, actually the estate might not allow it in terms of how many patients are waiting or recovering. So there's other factors at play when we think about how we optimise our systems and processes.
Dean, did you want to come in?
I was just thinking in terms of some of the actions that I hear coming out of that. We'll see from the medium-term financial plan the thing we can do, but I think I've heard there's a lot of data around acute, but there's a lot more to do. There's a lot more of NHS and care that we do that is not acute, that we haven't got the benchmarking to do. But that's not to say that we can't improve productivity, because it's a journey of improvement, not a comparison with others, because it's the improvement that we make that improves our productivity, even if we can't measure it in the same way that you can with the acute activity. I think to Dan's kind of point about bringing it into the productivity and performance committee, that's exactly the right thing to do. We'll develop this report. I think with Siobhan's help on the improvement network that is being created, we've got some insights there on how we bring that. So I think we will. I'll discuss with Sean how we bring that into our kind of planned care delivery group as part of the ongoing work.
Okay, next.
It was just about digital, to be honest. So my background is you may know. It seems to me there's a lot of bangs the book here, to be honest. But I get the impression we're providing this service to the acutes and rather than their own IT department. So I guess my quick question is have we the capacity to develop more? The opportunities listed here, can we actually invest more maybe in this area? Because it seems to be a fairly easy way of actually improving productivity, bringing resources for us.
When you say we're providing the services, you're talking about the example that Paul gave.
Yeah, so we're NHS Dorset, so but this stuff is actually related to the acutes, fracture clinics and stuff like that.
Primary care, but the providers do their own, and we're having lots of conversations about corporate services, what this means going forward, and the investment in the electronic health record will come between us. But I think also in the 10-year plan, the Secretary of State has already indicated there will be investment for digital in order to increase productivity across.
Lisa, then Matthew.
I think it might be worth flagging there's a difference between operational efficiencies and productivity and root cause transformation. And I'm saying that because we talk about wrapping in the prevention, cost savings downstream, and continuous improvement will only get you so far because it will only address the operational efficiencies and productivity improvements. But at some point with some things, not with everything, that continuous improvement journey will start bumping up against bigger root cause issues that we have to resolve, and they will require whole scale transformation. And that includes things like changing of the business models, changing of delivery models, changing of workforce models, changing of culture. So I think we need to make sure that we manage our expectations with continuous improvement. It can do a lot in terms of productivity improvements, but at some point with some things, we're going to have to move over and up that axis towards transformation, which is a much bigger job.
Thank you.
Thank you. So I just really want to comment on, Dean, on your kind of summary of some of the actions. So I welcome the broader focus that we're having around this table, and ultimately our task within the integrated care system is to get the most value from the Dorset pound, isn't it, in terms of health outcomes for the population. But just in relation to this data, I think that the presentation today is great. I think there's clearly a lot of hard work. I know that from the work that I'm involved in, and I'm only involved in one part of it. It's quite dynamic. So particularly in year, things move all the time. There's been significant changes in DCH, and actually our elective throughput for October is about 18% more than during Q1 as a result of opening new facilities, etc., which is very positive. But I suppose if I was looking at this critically, I would say I'm not sure what this tells us about productivity in the Dorset system or value for money where we are, and the opportunity that we've got. And I think that what we need to do is to commit to developing this and sort of giving it a harder edge as we go forward. So the conversation through committee, I think, which would replicate absolutely the work that we're doing in providers, is to say, if we're at upper quartile here, kind of what's the opportunity? So if we get the acute sector working as efficiently and effectively as possible within Dorset, how does that contribute to financial recovery, and what does it look like? And then how does that show up in the productivity measures?
Dawn?
Thank you. I just want to go back a point. I want to make sure that we don't lose what Lisa brought to the table there, and ask that we connect that continuous improvement, productivity, efficiency with strategic change. Because when we get into the item on our medium-term financial plan, you'll see how it'll be interesting for the board to have the discussion about those different buckets that we're seeing in that medium-term financial plan.
Okay, so I think, Dean, you captured some actions, which I think we would all support you moving forward with. I think some of the key messages coming out though is that we need to be more ambitious around how we are defining and then tracking productivity. So picking up Matthew's point, I think there was something also around how. So in the next actions that you're going to do, Dean, how do we involve the wider system in that? Because the other key message that's coming up is that we actually need to look at the left shift, and we need to look at prevention, we need to look at all those things. So how do we connect people into the work that you're doing at the moment around the IPR and other things? And then that last point around the kind of continuous improvement, and when it butts up against the transformation, how do we know when we're there, and then how do we move that forward? So I think those key messages coming out from that discussion. So thank you very much. Can I thank St. Paul for the presentation, the paperwork beforehand, for leading the discussion today, and thank you very much.
Nice.
Right, let's move us on then to the back. It's down as Rob. It's in your bag now, or is it David?
We spell.
That's fine.
Rob.
Yeah.
Because I saw David's name on the paper, but it says on here Rob.
I tried to pass it to Rob, but it's rebounded back to me. So apologies also for Leanne, who would have been here to support this discussion but can't make it today. So colleagues, this is the latest iteration of the Board Assurance Framework as at the 30th of September. By degrees, we've been working through maturing this document to make sure it's capturing the key risks and articulating them, key strategic risks, and articulating them in a way that makes sense with appropriate actions and starting to track those actions. And we're sort of banking the details as we go through the subcommittees. And it's coming with increasing clarity, but recognising there's still room for improvement. I'll come to that in just a second. So today's report is a kind of to inform the board on the recent round of reviewed risks that have now gone separately into each committee. So each committee is owning risks relevant to their work. And also the last time around, we invited comments from the committee to support that continuous improvement. Just to remind ourselves, the Board Assurance Framework is a new document and a new process for us in the ICB. So we've had to sort of look at best practice around other ICBs and develop this as we go. So just to update colleagues on the key risks that are highlighted in the papers, as you can see. What I did want to do is just draw your eye to the committee feedback that we've received, because I think it's important that we understand, recognising whilst we work through those risks and manage the risks, there's more we can do in terms of how we present this across the paper. So in sections 2.10 to 2.12, we've summarised the feedback that we've gathered through the previous round of subcommittee meetings. I shan't go through it all because it's all there for you, but the essence of it is trying to make sure that the document is clearer in terms of how each mitigating action or progress against mitigating action is improving or stabilising the risk score or the risk tolerance. So we will gather that up and do that in the next round that will go to the next round of subcommittees. And also to support that and to support members orientate into where the key issues are, we've agreed that we will further enhance the cover paper as well. So you'll see in the current version of the cover paper, you've got various sections on risk rating review, status review, assurance on mitigation. It's a standard report, and if you scan the paper, you miss the fact that there are no changes. And what we need to do is draw out what the key issues are, rather than repeating that. So we can do that in the next round. And also, we've already informed teams, leads via the chief officers, but also colleagues who support the development of actions and the writing about the importance of being clear on the work that they're doing, so that can be translated into this document. So the two things are, board may wish to comment on how the risks are progressing, what we're doing against the risks, and further comments on the work we're doing to continuously improve this document and the approach.
Thank you, David. I'm going to start by asking a basic question. and it might just be my lack of understanding. So if it is, then please correct me. But I'm wondering if part of the problem that we're having, particularly in terms of updating the BAF and the strategic risks, is because we are focused on risks. So our definition of what the purpose of the BAF is focused on strategic risks. For me, it's not focused on assurance. And I think that's the difference between a BAF and a strategic risk register. So I'm wondering, do we need, I know we talked about doing some work, didn't we, as some more work as a board and as an organisation. I'm wondering if we need to go back to the basics actually to understand what the BAF is and how we're using it, because I think if we can get into that assurance, it will help us at committee level, but also at the board. So
it should concentrate more on the control measures
Absolutely.
and the gaps in the controls that it does on the risk.
So with that in mind, then, so I'm happy for us to have the discussion around the strategic risk, but how do we want to get into that control agenda? Is it about inviting BDO to come back and do stuff with us, or is it?
I think they're already scheduled on our board development agenda to do that.
Yeah, in the new year.
Okay. All right. So would it still be helpful to pick up the questions that you've raised?
It's important that it comes here so that people, board members, can feel assured that the process we're endeavouring to do is checking and challenging it. We are collecting the feedback. We're trying to evolve and ensure the risk insurance now, as you're pointing out. So it's there in the paper. If there are further comments, that'd be great. But we're very happy to take it outside to continue that development.
Right, so I've got Rhiannon and Dan.
It was only to add to David what you're saying. My understanding is there's also the framework is being refreshed, which you didn't reference. I'm sure it was just an oversight, because partly yes about the capability of the board and addressing it that way, but it's everybody, isn't it? Because it's the application of how we use the BAF in reality, isn't it, in the context of committees, etc. So it's just to link that bit up as well.
Kind of almost thunder stolen, because I absolutely agree with Jenny's point. And then my other bit was, I don't think committees, there is something about the risk management policy and framework, and BAF versus strategic risk versus corporate risk. I think, well, I probably speak for all committee chairs, but definitely in my committee, I think we're struggling a little bit with how to use corporate risk and the BAF and strategic risk at committee level. And so in the kind of reset work or whatever it is, I think it'd be good to engage some of the NEDs and the chairs. So I think we can probably help. And it'd be good to kind of get on with it. I really endorse what we agreed in the summer, which was let's start using it and get on with it. But I don't think it's new anymore because it's 6 months old. And so we've really got to challenge ourselves to pace.
Rachel?
I think it was the point you just made, which was how you link, and I totally agree, having written a number of board assurance framework documents myself, it is about making do the board understand that the controls are in place and I've got assurance that the adequate controls are either through the executive or potentially how it links to your committees. So maybe it gives you a way through for your committees to take that responsibility. It would be good to understand how some of these key what are regarded as key strategic risks are fed through into committees, and which committee has got oversight and responsibility for assuring the board of that on its behalf, and escalating everything. So that would be something to I think we want to be clear about as well.
There's something going through my mind, which and I think I've said before, I understand why we landed on the 4 core aims last year. But I do think as we move forward, maybe when we have the conversation with BDO, I think we need to have a conversation with whether that's the right thing to focus on or whether it's the longer term aims that are in the medium term plan, and whether we need to agree what those priorities are that come through that over the next 3 years, and that's what should form the basis of the BAF. Because I'm still a bit uncomfortable with the BAF being focused on 4 aims. And that's what we're working to overall, but it's not grounded in the strategic medium-term priorities of
Okay, so I think we've got some key points to pick up there. Some of that we'll do with BDO won't we? But there is also, I think, some thinking that we need to do as an ICB. Okay, do you need anything else from us today then, David? So let's move on then to Patricia, your Chief Exec report, which is going to cover the current local and national developments.
Yes, so I'm going to take it as read. Three or four things I just want to pull out that I think might require a big conversation. So obviously we know that we've had the housing uplift now. It's given it, I think, a really good baseline overview of what the NHS is. And that will be the basis for the work that's currently ongoing in terms of the 10-year Health of the Nation plan. I think everybody accepts it is a fair reflection of where the NHS is. And so we need to build on that now in terms of the response to it. The 10-year Health of the Nation plan, the work has started. There are 4 different working groups. I'm involved in one of them. The intention is that all 4 groups report back to Department of Health by the middle of December, so that the Secretary of State has the time over Christmas to take away the first draft of the plan to consider what needs to happen next. I hope that means that whatever comes out of the plan in terms of the final version, that it will be ready in time for the ask to be built into the comprehensive spending review and that budget statement, what we'll see. We're going through a period of collective action, as we all know, with GP colleagues who are requesting a renegotiation of the national contract. At the moment, Secretary of State is reaching out to different stakeholder groups to collect information and evidence before the formal negotiation starts at a national level. We have had several letters now from GP practice PCNs who are engaging in different levels of action around the collective action statement, and we're working hard to mitigate those. What's important to us is how we move forward from the beginning of next year in the medium-term plan to support primary care as much as we can to be sustainable in the long term, but also to be engaged in the agenda around the leftward shift and the integrated neighbourhood teams. I'll leave Rob to talk and Dean to talk about the operating plan as we move forward. We had a workshop with colleagues, health colleagues, on earlier this week to look at the medium-term plan, and it was quite refreshing actually to after some very difficult conversations, I think, for us to get some consensus about where we need to go over the next few years to deliver the things that we need to. I think there's something about the board understanding the breadth and depth of the work programme going forward that we're going to need to pursue over the next 3 years to be able to deliver on the ambitions that will be outlined by government in the 10-year plan, but also bring the Dorset health and care system to a sustainable position, as well as taking account of the agenda around prevention. So we're starting to move into the work around healthy communities, and not just healthy communities, but communities that thrive and are self-directed. So just to give you a flavour of the size of the challenge, we've got the UEC transformation to do for urgent emergency care. We will have the integrated neighbourhood teams, which hopefully will all be up and running by the end of this financial year. But how do we, over the next 3 years, really strengthen, progress those and broaden the remit of them? The next step will be how we work with colleagues in terms of place around the wider determinants that support the work of the INTs. We need to have a much greater focus on prevention, and we've also got the new hospitals programme to land successfully the electronic health record across our health department, as well as developing, finalising and moving into an outcome-based programme. So there's a lot to do. The landscape is very complicated, and we're all going to need to put our shoulders to the wheel to deliver all that in the 3-year period. We've outlined some priorities that we've got for the end of this year, and particularly in the ICB, around the work that we absolutely need to land around the access and wellbeing for mental health transformation that Dorset Healthcare are leading on, We've got work to do to commission a new all-age neurodiversity service from the 1st of April, because we know that that service has been underinvested in over a number of years, and also that the waits for children and young people are far too long and are contributing to their ability to get a sustainable and comprehensive EHCP plan together. We also need to make sure that we're in a position to commission a new end-of-life service by the beginning of the new financial year, because our service at the moment is very fragmented and we're not supporting everyone that we should be to have a dignified end-of-life in the place of their choice. And we need to finalise our homeless strategy and make sure that that is rolled out from the 1st of April. So for the next few months, as well as managing a complicated financial landscape, we've got some really big pieces of work that we need to conclude and then start the new year with those pieces of work finished and a new commissioning process in place to manage them. The final point I would make is that we talk a lot about parity between physical and mental health in the NHS, but we very rarely achieve it. And so we've set ourselves an ambition, which I'm really proud of, but it will take a lot of work to get there, but we need to be committed to it, is that by the end of the transformation of mental health services at the beginning of 26-27, we want to be able to start the year with a set of measures for mental health that absolutely deliver parity with physical health, and that we are able to apply a zero tolerance policy to anyone with a mental health need or a neurodiversity need being admitted to a physical health facility, because we wouldn't do that to people with physical health needs, and we shouldn't be doing it to our community with mental health.
Questions, comments? Sure. Dan?
Thanks. I was just really struck by the volume of stuff going on. And I don't think often as a board we pause and kind of look at the whole landscape or look at the whole piece. And you just talked about an awful lot of things. So I just wanted to kind of reflect on that. I think a couple of times this meeting and I might do this, we've used the phrase leftward. I'm just conscious about buzzwords coming in. And I think we mean prevention. So just because this is the public part of the meeting, I just thought I'd kind of mention that. And then my question is on 4.2. And the development of the plan. It might be how it's written, but it feels like it's framed in the NHS part of the system. It does talk about integrated neighbourhood teams, but I just wanted to get a sense or some assurance that that work is looking across the whole system. It feels quite NHS-y in its writing, and so that is.
It will be, because the medium-term plan that we need to submit to NHS England is more predominantly about the NHS. What we talked about at our session earlier this week is our medium-term narrative around that, because Bex is currently writing a narrative document that's a business plan that is not just the schedules that need to go into the submission to NHS England, that it's a much broader plan than that. And we had our session with NHS colleagues this week. The intention is that in the middle of January we have a broader system workshop for the day with local government colleagues and our BCSE sector that talks about how where there is overlap in terms of the work we need to do together, and how are we going to structure that so that we get the best outcomes for our population, accepting that for all organisations there'll be work on the fringes that is only about their local plan and common purpose. And we've chosen the middle of January because by that point local government will have looked at their council plans, they will have signed off a draft budget, so we're in a much better place then to bring our priorities together.
Can I just really support that? Because I think one of the things we wrestle with often as a board is NHS compliance versus what we want to do for Dorset. And what I heard you say was, yeah, we'll tick that box, but we'll actually think about what we want to do. That's great.
Yeah, I mean, Gillian's very kindly stepped in to be the vice chair of our system executive group, and we've talked a lot about what the agenda needs to be if it really is going to be the decision making of the system. And actually what we're landing on is when we have those joint priorities through the medium term plan, that's the work that SEG should focus on driving.
And good challenge around the left shift, Dan. If I can just be really explicit, when I mentioned it earlier when we did the deep dive, I wasn't just talking about prevention. I was also talking about the shift from analog to digital, which came out in that, but also from hospitals to communities. So But I think it's a good challenge. Let's be clear what we're talking about. So I've got Rhiannon and then Forbes.
Yeah, thanks, Patricia, and really welcome the introduction of measures around the parity. So really good to hear that. Mine's also in 4.2 space. Obviously, there's an awful lot of requirement then around the introduction of the neighbourhood teams, and it's very soon. It's March 2025, and a lot of OD work needing to go into that. So I was just wondering how confident we're feeling currently that we're going to be ready in that sort of 2025, because that's a lot of teams, isn't it? 30 to 40, but it's essential for starting to make the shifts that we need. So just wondered the confidence really.
And can I add one of my questions to it? And I know Matthew might want to come in on this, but how many have we got? There's 30 to 40 by March. I had an intake of breath when I read that.
I'll let Matthew answer the detail of the question, but just so that you understand the rationale beneath the 30 to 40 is because we've been involved in a bit of work with the NHS Confederation about what successful neighbourhood work looks like. And one of the things that we absolutely are clear on is that the neighbourhood boundary has to be defined by the community, because when we start to build on top of that and we start to think about social cohesion, social capital, that kind of stuff, the assets have got to be recognised by the community and the geographical boundary that they want to focus on. So we've gone quite far in the conversation from boundaries that might be linked to PCN boundaries to actually this is about geographical boundaries that the community recognise. I'll let Matthew update you on where we are with the helpful and
Thank you. Forbes might want to come in as well, and Paul, because we're all co-sponsors of the work. But the work programme for the INTs is progressing very well. And currently we've got 4 set up and running or being established. So in terms of this bullet point update and what will be established by March 25. So this bullet point update also refers to place leadership. So the concept of place here is very important, really important for the Newton work as well, which we'll go on to discuss today. So I'm confident that the place leadership teams will be in place by the and integrated neighbourhood teamwork will have extended from its current position. We've got a rollout plan. All 30 to 40 teams won't be up and running by the end of March 25. There will be some things in order to support pace. There are some things where they're obvious and easily replicable, and there's widespread consensus that they need to be everywhere. The ambition is to roll those out in advance of the local team being fully present. So that's where we are. I haven't got the rollout programme in front of me today, so if you say, well, what's the exact number by the 31st of March, I can't give you the answer. But the programme is there, the work is going well, there's really good participation from all partners in it, and we can bring a more complete update to wherever is helpful within the integrated care board structure.
Have you got an estimate in your head around, so 20%, 50%? I know you haven't got the actual detail, but
I'm not going to give an estimate here off the top of my head. Paul might want to comment. Forbes, you might also want to
comment. That 25% of the taking point is in terms of control share.
And I suppose, Jenny, what I would say is always delighted to have kind of scrutiny, which I regard as a valuable addition to the work programme. I guess I am also in the position of challenging the work programme. So we need to go faster, and something follows a twist role as we're going more. But I think also it is important to listen to experts in this area who will counsel that this is a change programme for the long term. And if you want to do this properly and get the meaningful benefits from it that we believe are there and want, you need to make sure that you're giving the programme time to embed properly. And it's about a real change at local level. People learning how to work in different ways, in different teams to achieve the outcomes that we want. So I think we need to get our balance right between driving the programme as quickly as possible, but also listening to those messages about the space that it needs to develop properly.
All of the boards were invited in. I'm going to bring you first because Paul, you had your hand up anyway, so perhaps you can take up the invite and then go to your question. And then after that, I've got Nick and Dawn. Paul.
So a couple of things. First of all, on the oversight. So INTs are and will be a standing item in the Prevention, Equity and Outcomes Committee. So we've got it in there as standard because it is one of our key big transformation programs that we need to every 2 months have within our board governance, being aware of it. So it does sit there, and so there will be those regular updates, and then through the chair's report we'll be able to pass things through into board.
Okay.
Secondly, I think, to echo what Matt said about what Matthew says, there is we can give numbers, but the numbers will reflect where we've felt that we have launched the programme. That launching will happen in areas where there is a degree of integration already in place, and the launch doesn't mean that it's complete. So there will be then a period of maturing of those integrated neighbourhood teams. And so the number is a bit of misleading. It helps us know the spread, I guess, but it doesn't really give us the measure of the effectiveness. And I think one of the things that we are working on is how are we going to measure the impact that we're having through this program, or what are those metrics that we're going to be looking at? And that will come through, and I think that will be much more helpful. There'll be some that might be shorter term, there's some that will be longer term that we need to build in. And that'll be more helpful than necessarily the number that we've managed to reach, because it's at a point in time where there's already a lot in place, but it's also recognises that we are at the starting or at the beginning of a programme that takes time to embed and get the culture change and the different ways of working.
That's fine. The questions about numbers have come because that's what it says in the paper.
No, I know.
So, all right, Forbes.
Yeah, thank you. I wasn't sure if I should be saying consider yourself at home, Matthew. To your comment about all of our we're all good together.
Thanks, Nancy.
Yeah. You have to keep it rolling now, aren't you?
Yeah, I mean, let's not get hung up in the number, really. I mean, the number has been given, and you can model this in different ways. We're not at the number at this point in time because we haven't actually developed the local conversations that need to take place in order to establish the relationships to get to the number. Also alluded to, this is a phased process. What we need to do is actually accelerate those local conversations now, because we now have a programme structure in place, and it's the local conversations that will be the things that bear the fruit, that will create the infrastructure to make this happen. And so we've got the 4 early pioneer sites, early implementer sites up and running, but what we need to do is quickly roll that out. So it wouldn't be everything will be completely sorted within that time frame, but people will be, all areas should be on a trajectory to get there within a reasonable time frame. And we're actually working with NEPC in a maturity matrix, which will actually define that a bit more, so that people have some sort of clarity around what the aspiration should be in terms of maturity. So work in progress. Yeah.
Is that what you put your hand up for? Was it? So do you want to?
Yeah, my question. My question is really for Patricia and you, Jenny, and it's a sort of strategic from your position's question. You know, for me at the moment, there's a real juxtaposition, isn't there, between what the government's saying, what Treasury might be thinking, and what NHS are saying and perhaps doing as well. So we've got Darcy, great, absolutely saying the right things. We've then got all the operating framework, which is about we've got to manage acute performance, waiting times, etc. So who's giving you the thinking around how you're going to create this left shift, which we all know is what's going to improve the long-term outcomes for the population? Because I haven't been at a meeting where they've actually articulated that. We've had fine words about this is what we have to do, And I know we'll have our medium-term financial plan and fully support that direction of travel. There's not a lot new here, but I think we're at a critical time, aren't we, quite frankly, in our NHS and for the health outcomes of our and well-being outcomes of our population to make this happen. And I just wonder what you think is the process to get there.
You want to get in the hot seat first, Patricia?
And you may say nobody's got an answer, but you know.
I think that it will be articulated as much as possible in the 10-year plan. And the 10-year plan does not just cover the key steps that need to be taken and what the shape of the service will look like. It also talks about governance, how we need to change some of the oversight framework in order to make sure it's focusing on the right things and not just what we're looking at now, which is transactional targets. I think it will be supported by the reviews that are currently happening in terms of the work that Penny Dash is leading. So first bit CQC review, and now Penny's been asked to review the arm's length bodies that are responsible for quality and safety. And I think we will get into also at the point conversations about the link between those things and effectiveness and outcomes, rather than us always monitoring activity and throughput rather than the impact that the NHS is having on the health of the population. So I think all that comes together into a 10-year plan that describes how we move from where we are now to where we need to be. I think that will be supported by, and actually we were talking about this morning, some element of local government review and what that might mean for the partnership working at the next level. So the plan will articulate a lot of that. But I think some of it, we need to draw the roadmap ourselves. It's not going to tell us what we need to deliver and how we need to deliver it. And I think an important part of Bex developing a written plan for the system as opposed to just the schedules is not just about us articulating where we're starting from and where we need to get to. It's also about articulating the key pieces of work that need to be done in order to achieve the outcome, and more importantly, the sequence within which we need to do them, because we understand the connections between them. So I think once we've got that, we will have drawn the landscape for ourselves about how we make that level shift into more out of hospital work, a greater focus on prevention. And we started to look at the schedules that need to go into the plan that start to articulate that, particularly around what that means for the investment envelope in year 1, 2 and 3, and what we'd expect the outcomes and effectiveness measures to be that will be tied to that. Does that answer your question?
As best you can. I'm just throwing it out there really, because I think everyone, we hear all these things and we've got to then translate that into something that delivers, a narrative that supports the delivery, and for all our stakeholders, which is very much the public whom we serve. My colleagues working in general practice, others colleagues working in other parts of the system, and yourselves as within NHS management and the board itself. And I think we absolutely need to do what we can locally, but there's got to be some sense of what
I think we need to get into deeper conversations on a regular basis in the NHS about how effective we are. We celebrate very much the fact that we do more and more activity every year, but we've got to start to look at it through a different lens that says, actually, are the things that we're doing having a positive impact on the health of the population? And if they're not, we need to reshape what we are doing.
I think I've got two responses to your question, Forbes. I think the first one is that I think as a system, we have to be braver to move quicker, because I actually think the 5-year forward that we set down actually has things in it that we need to do. What we haven't defined is actually how do we actually get there? And a lot of it will mean double running. So, because you're not just going to move people into community provision overnight. They are still going to be visited hospitals. So I think there's some granularity around the plans that we probably just need to be braver at doing and make some decisions on ourselves. I think the second part, for me, is aligned with what Patricia's saying around the 10-year plan. And it actually was going to be my question at the end, which was, do we as a system want to put in a response to the government's consultation on the 10-year plan? Because I think there might be some opportunities actually for us to be putting something in. You know, it's out to the public, but actually collectively there might be some real power behind us putting in a response. So I was going to leave that as a question
when Kirsty comes in to talk about the consultation.
Right, okay, so then I've got Nick, Dawn, Cecilia, and Siobhan, your hand went up and went down. So do you no longer want to come in? That's fine. So Nick, Dawn, and Cecilia.
Mine was again on the woolly 30 to 40. I think we've answered that now. I think we basically don't know yet, do we? And it's all about geography stuff.
Yeah. Okay. Dawn?
I'm also going to come back to the integrated neighbourhood team bit and just briefly pick up the reference to the huge OD challenge, because I didn't want that to slip by. And as you would expect, there is a work stream and an OD strategy around that. But I just wanted to link it back to the assurance bit on the board assurance framework, because we've got a risk within 003 around system working culture. The OD strategy and approach to integrated neighbourhood teams is an example of assurance that we can bring, which shows the system working culture development in action. So this is culture development in an OD in real work within the integrated neighbourhood teams work. So I just didn't want to lose that point before we moved on.
Thank you, Celia.
And my point was basically, I think Forbes asked it even better than I did. So and it was how are we going to respond to that 10-year plan? What's our role going to be in that?
I think you knocked everybody's questions off.
I know, absolutely.
Well done. So it allows us to get slightly back on time, which is that we've got a break now, and we'll take 10 minutes. So if we can be back by, let's come back up at 22. We've got 12 minutes. So generous.
Are we ready?
I think so. I'll be back live. Thank you.
Okay, I mean, we had a very productive meeting, I think the last ICP meeting, and we had some very welcome news, obviously, from Patricia, that we'll get some executive support, which David Freeman will be our executive lead for now, at least until the disaggregation of the public health services, which is fantastic. I think we've missed having that. We had, as it says, strong representation from both local authority teams, from adults, children, and housing services, and they were describing great examples about how working together on many of which actually started before we established the ICB, but that they've increased in pace and commitment have improved the system working. We've got descriptions of benefits of working with the wider system partnership, and I would say to the discussion about the integrated neighbourhood teams, there was very positive comments, I think, about working in place, working in neighbourhood teams, and especially to the point that Matthew's making of that organic establishment of what those neighbourhoods actually are, rather than being imposed on people. I think that went down really, really well with that idea. We did see some great examples. I refer people to have a look at the ICB board with the reports if you're interested, but there was a lot of data provided now of how impacted services are improving through the system, and it's from our discussion this morning, we did get into a lot of discussions about how to measure productivity, how to measure performance, and how that should be taken forward. And there were several perspectives on what we should be doing. So as we're working on how to measure performance across the system, I think it'd be useful for ICP also to be involved in those discussions, just to find out again, so we can see progress. I think if people can share progress, which we heard from local authority colleagues with their programs, it is always encouraging for people to, oh, this is working, we should do more. The conversations are good, the examples are good, the metrics, I think I'll miss it and could be included. We also heard, housing colleagues were both present, and they are really making themselves visible across a lot of the range of services. And I think that's just full recognising that housing and its role in health as being a key strand across so many of the different things we're doing. So it's a big thanks for all that recognition, but I think it's starting to work well. There were obviously challenges. Again, people talking about working closer with NHS colleagues, finding the differences in the way that the governance system worked, the processes work, those questions, and how do we work better together, given that the systems do operate in a different environment and a different governance type environment, and getting better understanding of that. I think, again, Gillian, do step in if there's anything, but it did seem to me that colleagues were recognising those differences and hearing about secondments of individuals working in this, from one system into another, and getting that first-hand experience and how that works. Both health and wellbeing board chairs were present, and the related councillors as well, and they were again sharing their views. And I think that's been a positive engagement, and showing system working in that group, and talking similar language about transformation, about place, but we're still using place slightly differently. The best practice came out on a lot of things we talked about there, and as a metrics as to how to measure. We then went on to have a look at the three areas that we're looking at: cardiovascular disease, respiratory and frailty, and falls. And again, that out of hospital, all of the work they're doing, trying to link into, obviously, and lean into the work that the NHS bit is doing. What more could other system partners be doing? Heard from Sam about the success of some of the smoke-free 2030 programme that he's leading, the swap to stop treating tobacco dependency. But I think that there was an agreement that somewhere along the system must have another conversation about just the system view on vaping, because there were some things him being raised through the meeting. We did have a presentation from Charlie, who's our new BCSA chair, and her colleagues. So that was really interesting to see how that developed. And finally, we were joined by Rob Dabbs, Izzy Webb, and Dr. Francis Mitchell, who gave us a really fabulous, and I would say sort of data-informed targeting for prevention, sort of use of DICE for those who may be in fuel poverty this year. I think I just asked Sam and John the question, and he pointed me to Rob and the DICE team were already working on this with council colleagues, putting together data, and they gave us a great presentation that showed how we could target individuals. And I think I've just seen that the report has been put out as a standard report on DICE. It was a great piece of work that they were able to do between the local authority data and with our own health data that says that we could identify individuals which could be de-identified by the relevant general practitioner should that be something we wish to do, and link those to the packages that are already being made available by councils in terms of financial packages, by warm spaces already being delivered by local community teams, remote monitoring and other services. So again, if you haven't seen that DICE report, really do have a look at it. It is really an exceptional piece of work and just shows what we can deliver, I think, through the system. And it relates very much to CVD, respiratory and falls, because all of those conditions are exacerbated by cold. So if we can proactively get in and do something, identify to those individuals how we can support them, then that I think was quite an exciting one to look at. Thank you.
Thank you very much. On the DICE, I think we have got it scheduled for one of the board development sessions, haven't we? So any questions or comments?
Just wanted to make one comment, if I may, Jenny, which was on the presentation on the targeted winter support. And it got a mention in full council, at BCP Council, late on Monday evening when there was a debate going on about the winter fuel allowance, and other winter support, and Councillor Brown stood up and talked about the work, credited it to having seen it at the ICB, and shared that with Councillor in general.
Thank you. Thank you. Thanks very much for that, Gillian. Matt.
Thanks, Jenny. Good to hear the conversation going on about vaping. Obviously, we know the Chief Medical Officer's advice, if you smoke, vape. If you don't smoke, don't vape.
Yeah.
But there's a wider issue, of course, around some of this around criminality, unregulated, unlicensed products, and particularly around children vaping rather than smoking. So good to hear that conversation is happening, because it does pull in our teams in terms of our licensing trading standards. And I'm glad that we are committed to that.
Smoke colleagues were also raising the exact same point. So I think we need to work out really what the next step was. You've got people off the smoking onto the vaping. What could you be doing?
Yeah, so there are some national conversations around what government can be doing more in terms of regulation and legislation space. Which we have seen some changes just in the last few weeks, I think, around single-use vapes. But it'd be good for us to contribute to that conversation. So good to hear that.
Okay, so we're going to move on to the People Engagement and Culture Committee. And Lisa, between you and Dawn, I guess you covered the integrated performance, the workforce elements of the integrated performance bit. So this is also under the integrated performance. So can I leave you both?
Sure. Just a quick summary, and we'll incorporate the integrated performance as well. But a quick summary of the meeting. So we, like everyone else, I think, approved our terms of reference. We had a risk and audit action that I want to make sure that we pick up. It is on the action log for PEC, but we kept it open. The response on PEC, the risk and audit reference was that they wanted to show through PEC to make sure that we're supporting our staff during challenging financial times, and I guess that's internally and externally as well. And there are lots of resources on the internet, and if staff go onto that resource and have a look, they can follow links through, which is one of the answers, I think, to that reference from risk and audit. But we have asked to bring back to the next meeting more information on well-being in general, how we're supporting our staff through change, how we're supporting our staff through challenging financial times. And that kind of triangulates with some of the data we've seen on the performance report around sickness absence, mental health, as a real driver of sickness absence. So we just wanted to kind of pull all of that together and have a little bit more visibility of that. So that will come back, and that action is kept open until then. And we talked about risk, system supply, workforce, the medium-term recovery plan, because there is an impact. So we had a conversation about that. And then we went on to reporting against the performance report, and there were a couple of things really that we raised. One was that it would be good to see better forecasting as well as lagging data, so that we can start to mitigate risk before it plays out, rather than manage it as it plays out. It just gives us a little bit more of a forward vision on the horizon in terms of, and a good example of that would be the WTE target. So we know that
Do you want to say what that is? Just bearing in mind that we're in
the full-time equivalents, or the whole-time equivalent staff. And so we know, for example, that some of our providers are ahead of plan, some of our providers are behind plan, but all we've got for that on the integrated performance report is where we are now. What would be great is if we could get forecast data from the providers to let us know where they think they will be landing at the end of the year, because that will give us a sense of whether we're okay actually across the system, whether the ahead of plans will be offsetting the behind plans. And actually when you combine that, that's okay. And we don't have that data right now, so we can't start to mitigate if it looks like that's going off plan. So we had a really good conversation about leading data versus lagging data, and how having more leading data will help us to mitigate risk ahead of time, rather than just manage it when you're already then behind the curve because it's already playing out. So we'll continue to look at that in committee and continue to ask for more data and see where we can get to with that, so that we can be more effective at our risk mitigation. Also within that report, we're starting to see, not entirely unexpected, a tension between, because we really have been focusing, and the providers have been focusing on reducing reliance on agency staff and therefore bringing down agency staff costs. I have to say well done, because that's working and we're on plan for that. But there is a consequence of that, which means that costs on bank staff go up. It also means that the WT, so the increase in whole-time equivalent, can go up as well. When we look at the narrative behind some of those increases, it can be because agency staff is going down. So it's a bit like a graphic equaliser. So we're keeping an eye on that as well, to make sure that there are no unintended consequences, or where there are, at the very least, we're aware of those, and we can address those, or at the very least ask some questions about that as well. I suppose back to staff wellbeing and retention. We heard from DCH and DHC. We had a really nice session on the people promise, best practice there, I think. So they were talking us through what they were doing in relation to a people promise to help to retain staff and give staff a better experience, and it was just really good to see that in action. And I'll mention here as well that we had Rania Summerson, who is the new social care representative on the group. That representation flips around every year, and so Rania from Asian Care is the new representative there. And it was really nice as well to hear her say that she wanted more information on that. She would meet with the group and apply that into social care as well through her group, or her conversations about applying that. So really nice, just sharing best practice across partners and across the system as well. I think that is everything. I don't think I've missed anything out. Rhiannon, you were there as well. Dan, did I miss anything?
Dawn
was on leave.
Oh, you were on leave. Sorry,
yeah.
You did say.
But if I may, Jenny, because I was on leave, but there's something quite pertinent that it might be just useful to add in as an addition to this update. So so when we talk about the widening participation agenda that was focused on at the committee, what isn't noted here but useful for the board to understand, so Dorset is
an accelerator pilot for some work called Coastal Navigators, and this is about coastal addressing coastal deprivation. And given the current government's focus on work and well-being in the 10-year health plan, I think there's going to be a lot of good attention on Dorset and our ability to really grasp this accelerator opportunity that we've got, and it obviously will bring some more of this stuff back through the committee, but useful for the board to understand that.
Great, thank you very much for that. Dan?
You know who the other pilotees are?
Yeah, I do, but I couldn't really. I'll have to. I can find that out.
Please, thank you.
Okay, any more questions or comments? Right, so let's move on then to Prevention, Equity and Outcomes Committee, which is Kay as the chair, and obviously some of the IPR for this is the outcomes. But I noticed also, Kay, that you escalated the commissioning, this specialised commissioning, which is on the agenda for later this afternoon, so we'll pick it up then. And you also had something to refer to another committee, so well done. I'll hand over to you.
Thank you, Jenny. In fact, I will have very little to say here because a lot of what our committee talked about has already been discussed this morning. So we were escalating to risk and audit the discussions about the bath, but we've already had that discussion here, so there's nothing more really to add to what was said earlier. The other one that we talked about in quite a bit of detail, which has already been discussed today, which is the neighbourhood teams. And we very much welcomed the progress that we could see on that and the plans going forward for that, but it's already been discussed, so I won't go back over that again. Specialised commissioning is in fact coming to the board for approval, and it's recommended from the committee. We don't really have any significant choice in this anyway. It's like the pod delegation. We have to take it on, but I think it's going to be very important that we recognise all the potential risks that are involved in this, and that we make sure that those are captured very clearly for us as we move forward on this one. A lot of the meeting discussed the issues to do with the sustainability of general practice, and there was a really good discussion around all the elements within this. And this is not something that's new to us. We've talked about this several times, and again, a lot of the key areas in that have now been captured in the risk register, and they've pulled them out as separate ones. And you'll see when we come to the risk register that estates for GP has been added to it as well. But that was a really welcome discussion, and I think we got into quite a lot of depth there, and I'd like to thank Forbes for leading the discussion and for his presentation. It was very, very useful. Apart from that, we had our updates on GP access and the Women's Health Hub and the patient treatment activity annual report, which did show that the system that's been put in place is working well there. And really that was it, because as I say, most of the stuff we discussed has either been mentioned already here or is on the agenda for later on. Thank you.
Thank you very much, Kay. Any questions or comments for Kay? Okay, so let's go to Dan as chair of Performance and Productivity and Performance Committee. And of course, you cover the operational and the finance bits of the IPR.
Thank you. A lot of what's on here is kind of replicated on today's agenda. I think I get the award for the longest report, which I blame and thank Dean for, because Dean wanted to put some more information about the performance discussion we had. So that's set out here for board members, and I suspect some of that will be picked up when Dean presents the IPR in a couple of agenda items. We talked about the current financial position. I think that's held open for part 2 today, where there'll be a bit more of an in-depth discussion. We had a good conversation on PHC. I'd like to come back to that in part 2 about really where the committee can add value and kind of the pace and the vigour with which we're tackling PHC. But I think that's probably for after lunch. And then the winter plan, which is also on today's agenda. Questions?
Thank you very much. Questions for Dan? Okay, let's move on then. So to the area that's covering quality experience and safety, which is Rhiannon.
Yeah, thank you. I'll take most of it as read, but just to say a seamless transition, I think, from Debbie exiting retirement to Pam and team taking on supporting this committee. So we did approve the terms of reference, but we did have quite a conversation around it. Keen to think about how we can widen the membership in the right way and still need some further thought, and particularly how we bring the voice of the user into that committee space. It seems that it's a missing component really at this point in time or to date. So we received the patient safety and incident response learning report, noting the progress on that and some more planned work around the implementation of Master's Rule and pressure ulcers. And we approved the terms of reference for the oversight and shared learning panel. In terms of the integrated performance report, we know the progress being made around local maternity and the neonatal services. We were waiting some time for reassessment in that speciality or specialities. Also progress around child safeguarding and the implementation progress really of the patient safety and incident response framework. Because we'd seen an uptick in previous reports around MRSA, bloodstream infections, we did ask for a bit of a deep dive on that, so that was really helpful. It is an area that is of concern, particularly among the intravenous drug user population. It's not just local to Dorset, it's a national issue. And in addition, we're aware that C. difficile is also an area that has got an uptick nationally, but we will keep an eye on that through the integrated performance report. We also received the Care Qualities Commission. We were a pilot site for the ICE system assessment, and I know it's on the agenda, so I won't go into detail, but it was useful specifically for that committee to think how we can bring more of the learning element assurance into that committee, learning across the system, that is, and also that person-centeredness as well. I think they're the two areas we want to strengthen from that assessment feedback. We also received a report on medicines quality and safety report, which is a regular report we have, but we were quite concerned around the shared care prescribing of high-risk drugs elements and the impact of GP collective action potentially sort of early part of calendar year next year. So it was something we asked to be escalated to the senior leadership team in terms of handling the risk and thinking about risk mitigations. We were pleased to hear about the updates around child and adolescent mental health services and the Thrive model, excellent model. But we would like to see a bit more of the children's voice coming out in some of the reporting around that. As asked by the board, we did consider the CAS review and we can see the progress being made in its implementation within the Dorset health system. I think that's it really, Jenny.
Thank you very much. Any questions for Rhiannon? Okay, we'll move on to Risk and Audit Committee. John Beddett is no longer with us. So John, as a member of that committee, is going to, sorry, Rhiannon, as a member of that committee, is going to give us that escalation report.
We might have given it to Dan, but unfortunately Dan couldn't be there for all of the meeting. So I'll do my best. I won't do it justice, I'm sure. But yes, we absolutely did thank John for his excellent chairmanship. Rob did a really good job of thanking him. So we received the award of contracts without competition, noting there was only one contract. And I'm mentioning that because we felt there wasn't enough information being given to us so that we could understand the context of these awards. So we did ask for that to be more explicit, I guess, going forward, but there were no concerns raised with that award. So I should have said we did also approve the terms of reference for the revised audit committee. We took a verbal update around the replacement of the ledger, and it sounds like a lot of work going on in relation to testing and training timetable yet to be finalised, but we heard about the work in that space, and it sounded like a lot of detailed work was going on. In relation to update from external auditors on progress of the technical update, noting 23-24 mental health investment standard audit being initiated. What else do I want to focus on here? Yes, in relation to the task force for climate related financial disclosures, although there's no reporting requirements, we were keen that the organisation is on the front foot, so that there's a preparedness really in terms of what data can be collected for any future reporting requirements. So that was an area we'd like to be sort of picked up. We also had Mark Mansfield join us in terms of an update around the finance governance review, which was very helpful, very informative in terms of understanding what the sort of emerging recommendations and reflecting the risk. And I think it triangulated with other reports that we received. That was very useful. And obviously that will be focused on in more depth in part 2. What else? Oh yes, we also wanted to ensure that any of the digital actions were moved to Paul's as the Chief Medical Officer into his portfolio area. And there was an ask that the cybersecurity actions were expedited because some of them had been lagging a little bit in terms of completion. So that was a request by Audit Committee. So thank you, Paul's nodding there, so good. I think that's all I'll focus on, because I think we've talked about the risk elements anyway in quite some detail, haven't we? Thank you.
Thank you very much. Any questions for Rhiannon on the audit, risk and audit? Okay, so finally, we've got the Strategic Objectives Committee, and over to Kate.
Yeah, we approved the terms of references as we did for the Prevention Committee, although I forgot to mention that at the time. We received the Inward Investment 2 report and used that as a chance to also discuss the, to follow up on the discussion from the previous board meeting on inward investment. And we would like to, the committee would welcome the chance to be involved in a discussion about the future plans and the strategic way that is going to be handled in the future. In particular, we were concerned about areas where there could be significant funds coming into the ICB from various social partners that would need to come through the ICB because they are the commissioner for Dorset. And looking through that, we felt that we needed particularly to look at issues to do with a very, very clear ethical policy with regard to where we are, and develop a risk appetite as to where we needed to be with regard to inward investment, which really just followed up on what the board had talked about at the last meeting. We supported the research plan as we saw it. Our work with our research colleagues is really paying off, I think, and that was obvious in a recent conference I attended on childhood obesity, which Wessex Partners had set up. And I think that's something that is important that we continue to develop and build upon and make sure that we do integrate into our work. We noted and updated the updated risk on the EHR. I think the most enjoyable part of the meeting was actually the presentation on CVD, and this showed that that there's a real change being made here, and we really welcomed the presentation. It was engaging, it was informative, and what was clear is that there are green shoots coming through in terms of both prevention and also in some evidence about narrowing the inequality gap in this area, which it was only 1%, but it did show the beginnings of some green shoots there, which we should particularly welcome. And this fits in with a lot of what we talked about earlier, which is about the benefits management framework, which is really about making sure that in future we are focused on outcomes rather than process. And all of this, therefore, through the Strategic Outcomes Committee, really what we're trying to do. So we welcome that as a way of making sure that the focus is actually upon what we achieve at the end, rather than the process and just pious hopes about what we might hope to achieve. So it was a very, very useful meeting. Thank you.
Thanks very much, Kay. Any questions or comments for Kay? Lisa?
Just a comment on the CVD. I completely echo what Kay has said, and one of the reasons that it was so impactful, and Kay talked about outcome rather than process, is that there was a line at the end of that report that had a number of lives saved because of the project, and it brought our focus exactly to where it needed to be, because it wasn't a small number, and you could sit and think, there are people I know in that number who probably would not be here if this project had not happened. And so I think when we say we're really interested in outcomes, it's not being pedantic. It's so that the power of the work that people here do is really well articulated. And I think for me, all the time I've been here, that is probably the most powerful line in a report that I've seen, because of the outcome and the lives saved. They're real people at the end of that report, not statistics. So it was brilliant, and I echo what Kay said.
Was that Will's work? No.
No, it's Martin Longley.
Yeah. Well, whoever the report authors were, I think we should pass our thanks for that, because that is really powerful, isn't it? So I've got Patricia and Forbes and Paul. Are you indicating?
No, I was about. I may have to come in a moment, but at the moment I'm keeping quiet.
He's been in a very cheeky mood this week. I bring Forbes in.
Forbes.
Just a very brief comment. The CVD. So the key word here is prevent.
Yeah.
And it's exactly the type of work that we should be doing and where we should be focusing our efforts, because the outcomes are extremely good, and it's hugely more cost effective than CVD intervent, which is what happens with regard to sort of secondary prevention, as Patricia's mentioned. So if we're going to learn any lesson, then this is exactly where we should be focusing our efforts and our investment.
Agreed. Perfect. So I was just going to say that, given that work on CBD, respiratory and falls and frailty are the priorities that we chose for this year for the joint forward plan, it probably is opportune for us to have an update at the next business board meeting on where we are with those three programmes. That'll give you a sense of the outcomes that we've achieved, actually, the change in behaviour and approach from the clinical teams, which has been really refreshing.
So that's I think our key messages from the IPC, isn't it? It's bring those three back to a future board meeting, but also to note that the focus on outcomes is really where we really need to focus as an ICB. So thank you very much for that. Paul, you do want to come in now?
No, first of all, that I think that's a good idea. And I'll make sure that's in hand and that happens. I think we need to. I think it's right that we congratulate the teams on the work that they've done, but that's been because there was a huge amount of lower hanging fruit, because we and in line nationally, we're in a really poor position in the way that we were identifying our people with hypertension and getting them under adequate control, and we've gone from really poor to still poor, despite the improvement, and so I think that this is the start of a journey that still needs to get much, much better in the way that we are managing our patients out there with known and unknown hypertension.
Okay, thank you. Right, let's move on then for our item 4 decision, which is committee terms of reference. And apologies, this is off and I forgot to check who's going to do this. So David,
Yeah, that's uncomfortable. So colleagues, this is for decision. So we've heard actually through the last tranche of reports about how each of the committees have reviewed the terms of reference and membership. It's good practice to review the fresh terms of reference on an annual basis, on a regular basis, and also because of the restructure of the chief officer and the directorates across the ICB. We've also taken the opportunity to review membership, and those were endorsed and approved by the committees. So it's here for the board's final formal approval. I would just, it didn't come out in the other conversations, so just to highlight, so you can see the table in section 1.4, which demonstrates where the changes are. So it's mostly to do with membership and no other revisions except for the Strategic Objectives Committee, whereby we've added amendments in terms of reference in Appendix 2 because for some reason we missed standardisation elements of that section when we did the revisions of the last time round. So that just brings it in line with the other committees. And the one below that, the REMCOM, the Remuneration Committee, there's just a punctuation. This is how precise we are. A punctuation amendment which you're asked to approve. But just to make that really clear, that you know, that's the kind of level of scrutiny that we've gone into to check that these are correct and accurate. And then the second part of what's in this paper today is about the ICB constitution. So NHS England nationally have issued some revisions to the model constitution, which we've reviewed and tested against our where we are, and we've outlined in section 1.7 what those changes are. I shan't go through all of them, but you can see it's from the basics of, because at the time the model constitution was done, we were referring to the establishment of the ICBs, and now obviously we're clearly fully established. And then to things from basic things like that to more substantive things like the appointment of deputy chairs and the tenure of non-executive members and chairs tenure as well. So those are outlined in section 1.7. Other than those changes, there are no other changes recommended for the constitution, and the documents supporting the terms of reference and the constitution are available for review, but have been reviewed and endorsed by committees. That's all I was going to say. Invite any questions or comments.
Thank you. Questions, comments? Are people happy to approve, including the typo or the grammar? Gillian, you don't want to approve things.
I'm happy to approve it, including the grammar. It's just a question about potentially whether it's a future iteration of this. We're doing lots of thinking, aren't we, about place and the role of place and place-based partnerships and place leadership teams. And while they aren't, I suppose, formally part of that NHS front and board constitution piece, they are going to be. So whether we want to capture those and bring them to the board at some point, whether it's part of this framework or a different framework.
Sorry, go on.
No. So yeah, exactly, Gillian. It's on our work plan for the coming phase. So we know we were going to do it anyway because that's the right thing to do. Because we will want to be getting to a place where, with increasing maturity, we'd want to be considering delegating decision making and potentially budgets to place-based partnerships from the NHS out to that. But also we want to take account of the changes coming through as a result of the 10-year health plan, because that might change how we want to focus what we do and the structure and the format of the responsibilities of each of the committees. So we will pick that up as an ongoing piece of work for the reviews that we want to do. And if you refer all the way back to the beginning of the meeting, there's an action in there about how we further improve the processes and functioning of the committees as well, in the nature of reports and all that sort of stuff. So we're picking that up as one big tranche of work, but we'll definitely take account of the emerging place-based partnerships.
Yeah, because I took from what you were asking, Gillian, to link back to when we were talking about integrated model teams and about populations defining their place. So that might not be what you meant. I don't know.
It wasn't. It was a slightly different point about place-based partnerships as governance, where we record that.
Okay, yeah, that's fine. Thank you, Matthew.
Thank you. I think that's a really important point to consider as we go forwards. But David, in relation to this paper, I guess my question is prompted by the Strategic Objectives Committee terms of reference, but it's a bit of a broader question. So in that terms of reference, you've got kind of 2 NHS partner representatives, and I'm wondering how they're being determined, who they are. And then that leads me to a question, which is, if you look at that issue across the subcommittees, my question is it working or not? Is there a better way of doing it? And like, I don't want to bring my kind of personal diary issues to this board. That's inappropriate, but like, I really welcome being a member of this board, and I welcome being a member of the 2 subcommittees that I'm a member of. But I've also got the 2 boards I work with. So when you begin to add up the time through the month, that's quite a lot of commitment. And I know in reality, I attend one of the subcommittees more or less all the time, and I failed to attend the other subcommittee on most occasions. And I'm just wondering, and I'm looking in Sean's direction, whether perhaps we could work with you through the provider collaborative and sort of take a look at all the points that you would like provider representation and agree to do that in a team-based way, which might also have the benefit of, you know, binding us together as a system and thinking about the information flows from these committees through to the provider collaborative.
I'm not going to invite David in to respond. I'll do a quick response to that, which is yes, let's do that. In part because as non-executives, we had that conversation last month. We're conscious of the demand, particularly on yours and Siobhan's time. We ended up by saying, well, the committees are constructed in the way they are because it tends to be members of the board. But actually, does it have to be that? So I think that's exactly right. Let's have the discussion and see where we are. Absolutely,
yeah. It doesn't have to be.
It doesn't.
But you need to feel comfortable with it.
Yeah. Okay, Lisa.
Just a quick one, because I should have said it in the summary for the committee and didn't, and it's not explicit here, is that we did have a bit of a caveat when we approved the terms of reference for people engagement and culture, that we were going to explore whether we could better represent pharmacy, optometry and dentistry on that committee, because it is there, but we're just going to talk about later whether it's there, whether it's strong enough, whether that was. I just want to note that.
I think you're unleashing all of the non-executives now, Rhiannon.
Yeah, it's just to emphasise the point, because the point I did make actually in the escalation around it's not even widening the participation, it's having people that are actually able to contribute, and that's no criticism whatsoever, but we're missing that inject from the right people. So I think we're just welcoming that conversation, really. Thank you. Okay.
Right, let's move on then to the winter plan. Dee, you can take us.
I introduce that. So there is a document which summarises where we've got to with the winter plan. You'll the last 2 winters that we've been part of, the winter plan is there to check on kind of the capacity that we've got for the winter, but also the processes that we use, the day-to-day management and the escalation processes that we have in place for the winter. And our operating plan that we developed at the beginning of the year, it set out the activity, the amount of capacity that we have in the system, the number of beds, and what changes we were going to make to the system. In particular, things like the improvements that we were expecting and planning for with urgent community response, with virtual wards, changes to the way we run our short day emergency care units, the introduction of the care coordination centre staffed by a paramedic. We've kind of built a model that showed us what capacity we needed to do that, and that's in our original operating plan. We've revised that for the winter, using the first 6 months of the year to identify that. I think the biggest change within that is that we have seen a 10% rise in the number of emergency admissions that we've experienced over that time. The majority of that has been experienced at Dorset County Hospital. When you look at the metrics that we measure for urgent and emergency care, we've got one that has been difficult for us all year. Now, to resolve. When you look at all the others around A&E 4-hour standard, the ambulance handover times, the category 2 response times, we have done well all year, and that is we expect to maintain those over the winter. There's been a history in the NHS of there being winter money. There's always been winter money. That hasn't been the case this year. Last year it was included in the settlement, so there isn't any further investment that we've got. And I think that's really pertinent here because of the amount of capacity that we put in last winter. There were over 100 escalation beds put into the system this year. We have funded kind of 20 beds this year. That's what the recurrent position of the ICB has been meant that we could put in place. So we had the urgent emergency care delivery group last week, where each organisation brought all their plans together, and of course they were very similar in terms of what they were addressing, because we had one plan for the year, and the winter time actually reflects that. When we look at the capacity, There are peak times over the winter, particularly in January, where there is a kind of surge in demand where we need to satisfy, and with that, that's where our biggest problems come. And when we go through the modelling, we can see our way through that, but it is dependent on the delivery of our no criteria to reside reduction plan that we originally set, which we are currently not on track with. And that's really is the major point of the winter plan that I want to bring out for the board, is that it depends on the delivery of that no criteria to reside plan. All of the organisations sat around this table have committed to that no criteria to reside plan, and we need to deliver that by this winter. So the main parts of that plan are kind of 3 parts to it: preventing admissions. So we've got diversion straight to same-day emergency care units, the utilisation of the virtual wards, the step-up services that we've now got for the virtual wards, rather than just being kind of from step down. We've got ambulance diversions. So we've introduced the care coordination centre. So we've got a paramedic there working alongside our urgent community response and the voluntary sector to divert people. That started at the end of September. We've got diversions from A&E straight to our same-day emergency care services, and they are changing to reflect kind of the frailty and the pathways that we've got across the agenda. The next kind of part of the plan is the reduction in delays of our supported discharges. So that's what we call pathway 1 to pathway 3, people who need to go home or into longer term care. We've introduced this year our transfer of care hubs. One of the pieces of work that the early pieces of work that Newton are supporting us this winter is really the maximising of those transfer of care hubs. And that's where we think the majority of our benefit will come this year, is because having the people who can facilitate discharges all working together under one framework will help us get those people to the right places when they need it. We've introduced new ways of identifying risk factors before people get to the point at which they need to be discharged, so earlier discharge planning, and we've got escalation processes in place that we've revised and enhanced for those patients that are the most complex ones or just are getting stuck in the system. We've set our metrics during the year. So you'll see in the document there are weekly discharge targets that we are looking to meet for both not just the acute but also the community hospitals and also in our reablement beds. We have place-based improvement teams that have been working all year. We've just started one for mental health as well. So we're bringing mental health, bringing that theme of authority of esteem with physical health as well. And that's one place where we have had some success during the year. Also improving the number of discharges that we take place at weekends, and having the same rigorous processes that we've got in the acute settings into our intermediate care setting as well. So this has the commitment of all organisations, kind of both here and in the urgent care delivery group. Are there any alternatives? Because I think the board probably needs to know, are there any alternatives? I think the only alternatives to the plan that we've set out here is it would mean more commissioning more activity, which is something as a system we've not been able to commit to. Just like to also mention the mental health kind of resilience that we've got over the winter. I think we've seen, certainly I've reported here, the improvement that we've seen in the number of people that we've had to place out of county for inappropriate out of area placements, but also the number of people who are waiting to come into the mental health ward has reduced dramatically during the year. And we are frequently in single figures when you combine those two numbers together. That has been due to the changes in the way that the Mental Health Trust has worked and the flow team that they put in. Last winter, we were at Opal 4 all winter for the mental health. This year, so far, we have been at Opal 2 for the majority of the year. So we've seen a real improvement in that. I think the risks that we've got for this winter, the GP collective action, that is ramping up. I think that's what certainly the trusts are seeing kind of some increased activity from. Second risk, our delivery of our no criteria to reside plan. That is what the plan is predicated on. And also making sure with the increased focus on quality that we've got and not using temporary spaces, is that we are not having those handover delays that means that we need to create temporary bed spaces for people to wait in until they get to the next part of their care.
Okay, thank you very much. Pam.
Thank you. I just wanted to add to that. I think we always draw breath as we're about to go into winter, because we know that the risk of harm increases exponentially during that time. And I think, just reflecting, these conversations are very live. We've got a number of controls in place, a number of opportunities in terms of how we are monitoring this. But I think there is an additional complexity this year, as Dean has alluded to, in terms of GP collective action, in terms of we are constrained in terms of spaces we would have historically moved into in terms of escalation and stuff. So I think there's an added dimension to that conversation this year, which is very live in terms of what more can we be doing and how can we track this really early if we're seeing emerging themes as well. So it's just to give that assurance to the board that these are very live discussions around how we will be responding.
Okay, so I'm going to go to questions and comments, but do you want to come in first, Patricia, and then I'll go Siobhan and Rhiannon?
I mean, when we will come on to the finance report later on, but needless to say, we are adrift of our the agreed financial plan for this year. And I'm sorry we keep talking about delayed discharge of no criteria to reside, but it is absolutely critical that we do not go into winter with the level of no criteria to reside we've got now, because there is absolutely no wriggle room in our finances to be up in additional NHS hospital beds. And to be frank, we shouldn't be doing it anyway. One, it's the most important part of the system, and two, we shouldn't be keeping someone in a bed or admitting them because there is no alternative. And at the moment, we've got far too many additional beds open because of that reason, and we have no financial flexibility to manage that through the winter. So I would ask colleagues to do whatever you can to bring that number down and keep it down over the winter. Otherwise, we're going to hit some very, very difficult situations where we're going to be into OPEL 4, which is avoidable, and then we'll be pulling everybody into escalation meters all the time, and that's not where we want to be either.
Okay, Siobhan.
Probably on the back of what Patricia said, just to say, our winter plans, I think, as providers have all been signed off at our boards. Within UHD has been quite an interesting process, and actually we've had a lot of clinical engagement in our winter plan and a real emphasis, obviously, on not opening additional capacity within the hospitals. And that actually has gone really quite well. So, I'm actually quite positive about our same day emergency care, working in virtual wards, really looking at alternatives, looking at our admission criteria and our admission rates, and also our length of stay. So these are all things that we need to do to get ourselves ready and in the best place for the year following, where we're making our significant changes. So actually, it's a good run-in. The risk and the challenge is obviously patient safety through winter. And I think in your paper, Dean, the point I'd probably like to just emphasise is, if we open additional capacity, that will jeopardise our year-end financial position in all providers, which will add issues into the financial position for Dorset. So actually, we all need to be on the same page. And the real thing here, I think, is about our conversations about risk and risk appetite across Dorset. And I note the enhanced risk share approach, which I really welcome, but I think our maturity around those risk conversations probably needs to step up again, so that actually we have some very honest conversations across the system about our risk tolerance and where that may be different or the same, and how we really risk share this winter. And I just wanted to make that point. Thank you.
Okay, Rhiannon and then Forbes.
Yeah, Dean, I suppose from my perspective, I would anticipate seeing at least a bit of lean into some of the prevention elements. It's silent on that. So obviously the uptake of vaccinations, I think if I understand correctly from the data, aren't too bad, and maybe they don't have too much of an impact, but I think we should be practicing what we preach in terms of being a prevention focused ICB. So I'd like to see some reference to that and some recognition of how we're looking at any health protection intelligence that we might have in terms of projected disease patterns, some particular, impactful respiratory type diseases. So that we're not getting any of that in terms of understanding what might be coming down the train track, if that.
Okay, folks.
Yeah, that was exactly my point, really. I wonder if we should be front-ending this a bit more. If we did make some proposals early in the year. I absolutely accept it's difficult, and absolutely accept you've got demands, no criteria to decide. But surely the emphasis is on about admission prevention in the first place. That's part of Newton's work, isn't it? We did make some proposals around respiratory hubs, and a small project that worked quite well in the past. It was commissioning extra activity, but when we gave the study through, we commissioned a bit more activity from general practice, which helped manage the acute demand, which as a whole is usually much more expensive activity. I think the vaccination programme, I think we should be doing all that we possibly can as a system to encourage people to get vaccinated. COVID vaccination in Dorset is still going quite well compared to other places, but is it what it could be? We're vaccinating for flu, we're vaccinating for COVID, and we're vaccinating for respiratory syncytial virus. The more people get vaccinated at the moment, the better outcomes we will have in terms of winter demand for those conditions. So surely we should be doing that, as well as all the local authority community support work, which actually helps at a local level. So I think front-ending this in terms of prevention is something that we just need to reflect on.
Quite interesting, actually, because during COVID, that's exactly what we were doing, and then mapping that against where we thought we would be with COVID. So we should still have the ability to do that during winter. So really interesting. So then I've got Dan, Matthew, Dawn. Do I miss anybody? Dan?
Mine's related, but not, because the winter plan came through the committee. We talked about Newton a lot today, and it might be I've missed it before, but is board briefed on what the work is and how it faces off into our risk profile and our financial position and our ROT plan and quality? And it might be that we do that when the work comes through in conclusion, but it's just been mentioned in a few places, and I'm not sure board's fully aware of the scope, and maybe that's right. And so
did the final answer, and yeah, when we do, we'll need to bring it to board over.
Yeah, it should be good to understand informally or formally how it all fits together.
Okay. Matthew?
Thank you, Dean. So I think there's been very good work in this area. I kind of agree with the points made about the importance of looking at prevention, etc. I think in terms of the content of the paper, and I guess kind of you've got 2 or 3 main risks here, haven't you? There's a risk about the demand assumptions, which the team have done their best to mitigate by recalibrating. And then there's a risk about the kind of supply options, as it were. And the biggest, or the 2 biggest risks there are the assumption that no criteria to reside can be reduced to the agreed levels. That's quite a big risk. And the second thing I think is there is a risk about the assumption on bed occupancy, because we've got differential bed occupancy across our system. So there's an assumption it increases, but will the capacity be available in the right place in the system? That makes sense. I think those are the 2 biggest risks. I think in terms of kind of further mitigation of those risks, there's a lot of good data proposed in here about numbers of discharges that are needed, and also the actions that are in the appendices. And what I'd really encourage us to do as a Dorset system is, having got to this point, now, in my view, we must follow that through. And sort of what I would request is that as the leadership team looking at this are getting, and there will be daily data, but they're getting on a weekly basis data back against the metrics set out here. So we know whether we're getting the required discharges per week. We know whether our discharge pathways are working in the required times that are set out. That will tell us whether we're going off plan or not quite quickly. And if we're going off plan, we'll need to take additional action.
Okay, and Dawn?
Yeah, thank you. Just to speak to the front ending in terms of protection, Kirsty, I'm sure would never forgive me if I didn't mention the comms and community engagement work that is wrapped around this winter plan, particularly the Stay Well website, which is across all of our partners, supporting people and communities around warm spaces, vaccinations, and the stuff that sits at some of that front. That doesn't mean that we can't do more, but I just wanted to flag what sits around that work.
Lisa?
I just want to build on that, and because that came through people and engagement, and I really do want to congratulate Kirsty and the team on the work that they've done on an almost non-existent budget as well, if we're going to talk about efficiency. They are really working hard, and and working hard as well now in terms of what are the outcomes from this, and how can we, so that there will be some good information and some good data coming back that we can then use next year as well. But I just thought it was worth congratulating Kirsty on that, because they are working hard and they're working effectively and efficiently.
Thank you. So in terms of sorry, Dean,
do you want to just come back on a couple of those points? Because I think really important points, particularly the vaccinations one. We run the vaccination programme. The rates in Dorset are kind of one of the best in the country still. We were at that head of the kind of league table from the first week of the vaccination programme. But I think it's definitely true to say that the vaccination rates are dropping off. Kind of, we're expecting to get up to kind of between 65 and 70% this year. That is not the level that we were at during COVID. So that is a risk for that. And Matthew, particularly on the data and the monitoring, that's exactly what we do through the weekly improvement groups that we've got focused on the two place bases and now on mental health. We will make that data more visible. So through the System Control Centre, every week this year, we have done our headline metrics, kind of how are we doing. We will add to that now, kind of how are we doing through these winter metrics as well. So it's a good prompt to make that, I think, more visible to the leadership community, because it goes into the UEC delivery group members and also the weekly place-based improvement groups that we've got, but kind of I'll make that more visible.
Great. So that was going to be one of the key messages, the front end of that work. You're saying we're doing that, so yeah. So we'll leave you to increase the visibility on that. There's something around Newton and bringing the board up to speed around what Newton are doing, what the impact is that we think it might have, and where they've got to. Siobhan raised the question about stepping up our risk appetite and our risk share, and I think in part it also came up from one of the last comments that Matthew made. How do we do that? So what's the actual practical thing around getting that done? Gillian?
Jenny, I was actually going to come back on that point from Siobhan, and I wonder if it's in each of the places it's a discussion, because there's a very regular collaboration between our teams at the WIG meetings, and that's happening. But I wonder if it's about a more senior level discussion ahead of the escalations and ahead of the heat coming, if it does, to say what do we mean by that? What do we mean by risk sharing? Scenario plan it out, and just do that with a cooler head rather than in an escalation zone. And from our side in BCP, I'm really happy to conversation and have it with partners.
We're getting lots of nods, so I think you should
I think we need to do that, because we all have our statutory responsibilities, but there will be moments where one risk trumps another one, but we all need to be on the same pages about that, because the risk we're taking, because we all need to be able to articulate it to the Care Quality Commission if we end up in that sort of conversation. So I think Gillian's right, having that discussion before we get into escalation and agreeing the way we want to make those decisions.
Okay. Did you want to add anything? All right. And then the final thing was really just the congratulations to Kirsty and the comms teams for all of the work that they're doing behind the scenes to actually get the communications.
Or behind the pillar, not
so behind. Right. Well, thank you very much for that really useful discussion. But the next two items are here for noting. They're not down as discussion items. And we have actually had feedback. So Paul initially, and then Pam secondly. I want you to work on the assumption that people have read the paper, and I'm just coming to you to see if there's anything that you want to add. I'm not going to go out for Q&A because it's not so.
No, this has already gone to a committee. It's coming here because there is an NHS England ask that we bring to board where we are on this programme of work. And I think what it demonstrates is that we are making some really good progress. There are a couple of risks, and I think they have already come up in other conversations around the progress that we're making. But I think it's testament to the good work that our GP practices are doing, despite the difficult, challenging positions that they find themselves in.
Thank you very much. And then Pam.
Thank you. Thank you. And equally, I'll take the paper as read. And obviously, there is some national headlines around this in terms of ICS assessments have been paused at the moment, not stopped, just paused. But I think certainly from a Dorset perspective, it will put us very much on the front foot when they reignite again. And actually, in terms of the framework and key lines of inquiry that they will be undertaking.
Great. So we can note both of those. And then I think that takes us on to the intensive and service community mental health team review.
Thank you.
Is that you? Thank you.
So this paper is here because this is a piece of work that's been requested by NHS England after the tragic situation that happened in Nottingham where 3 people died. This is the first stage of the work that we are doing. Dorset Healthcare has also done their own report. It's also gone to their board as requested by NHS England on this. And we as the Commissioner have been requested to do that as well. And Mark was part of this work. It's to ensure that there is appropriate, intensive and assertive mental health care is available, especially to those who've got severe mental health and those who may struggle to consistently engage with services and their treatment. So we've used the NHS England guidance to review policies and practices and to start that work. There were 17 site visits, and Mark has just joined the meeting, was part of those. That involved talking to patients, carers and staff during that process. And the assertive outreach part of the service was fully assured during that process, and that was part of the assessment that went into England. We also reviewed the community mental health services as well, who do care for some of these patients as well. And due to the wide range of those clients and those services that there is that's where there is more work to be done. So the next step is there is an action plan to be developed, and I think I saw yesterday that the start of that action plan has started to come together. In December, it's proposed that this goes to the Quality and Safety Committee for oversight, and that we use the Quality and Safety Committee to seek assurance on the action plan as that goes forward.
Thank you very much, Dean. As you mentioned, we've been joined by both Mark Smith and Julie Walker to assist with the discussions here. So should we go, was there anything you wanted to add, or should we go straight to Q&A?
I think
straight to discussion.
Hi everyone. I think Dean's given a comprehensive introduction to that. It was always going to be quite a fast-paced review. NHSE set quite a tight deadline. We did meet with 17 different teams across Dorset Healthcare. We had some really good engagement. There's some really good open honest conversation. But this is the first step in a longer term process. We've got weekly check-in calls with NHSE on this particular subject as well. So the development of the action plan is the next bit. And that will be co-developed with partners, because supporting this cohort of people is not just about NHS health services. There's police, probation, prison services, drug and alcohol services, local authority. There's other aspects to it. So that's the next sort of step. And the sense I get from NHSE is that this will continue into Q4 and probably beyond as well. Yeah, we're here to take any questions. Julie and I both did the visits together.
Great, thank you very much for that, Mark. So any questions or comments, Rachel?
Yeah, thank you. Just a comment. I think Dorset is the only area, one of the fears with the assertive outreach. So that's really positive in that you're starting from that position. So I think firstly to acknowledge that. But I think that then there's an ask for a lot more detail because you've actually got the service. So I think good to see that the Quality and Safety Committee will have that oversight. I think the team's reflections on what they saw and what they've heard is they'd be keen to get into the detail, but building from a positive place.
And it's probably just a sense because it probably is that detailed work. I was just struck in the key messages around the no wrong door approach, which is obviously the right approach. I'm not asking you to quantify, but it's just a bit of a sense how far off we are from that no wrong door. Is it a million miles away, or it's an unfair question to some degree, but it's just trying to get a sense how much work there is to get us to that place, because it's the right aim, isn't it?
This colleagues are probably aware of the large and complex community mental health transformation anyway. That essential to that is the no wrong door, the warm transfers between services, and no rejected referral principles. It's dependent on each part of the system, each team, each member of staff, each organisation working in quite a different way culturally. So there's areas where there's some good progress. There's areas which need a lot more focus. The question is a really difficult one to answer.
Yeah, I knew it was, but there's learning to draw from, isn't there, from children's services is what's going through my mind, because it's something that they've had to really grapple with, and I'm sure, I don't know, people may say haven't quite got there completely yet, but I just wonder how much you're drawing into colleagues that have done it or are doing it for other topics.
I mean, we spent, well, I think this started in 2019, the whole transformation stuff, and it's still ongoing. There's a very large group of stakeholders that we're learning from. People that are doing it quite well, others that are just starting out. I'm not sure whether we're linking in as well as we could with children's services. Obviously, there's this CYP transformation happening as well at this point in time. So, yeah, it's a way off. It's an evolutionary thing which will continue to evolve and develop. The will is certainly there. Everyone is bought into the principles and the ethos of it. It's a case of putting it into practice, and that's easier said than done. It's reliant on staff, teams, services, organisations working in quite a different way.
We know cultural transformation is.
Yeah. So it's a really important question. I think, and forgive me if I'm making a very obvious statement, but I think in terms of our oversight and governance around this work, we just need to maintain clarity about what this is about, which is a particular cohort of people with relatively complex needs. And I think the work presented here is very helpful. The actions suggested are the right things. And as we take forward that action plan, it may be helpful to include some numbers in this paper so that we're actually defining what the population is and we get a sense of that. There's certainly a conversation going on through the Southwest Mental Health Provider Collaborative about comparing and contrasting over the region, work around this, and I think that's something that we should do to take a look at what we're seeing through our ICB and compare that against the other 7 systems across the region. So the care for this group, and clearly the identification of this group with relatively complex needs, sits within the wider ecosystem of mental health that isn't just health services, it's about the BCSC access, well-being, and primary care, etc. And certainly the kind of the ethos of open mental health and kind of no wrong door is a central part of that change. So that's really important, but we just need, with this exercise, I think, to come back to the specifics of how we are caring for and managing risk with this group and make sure that we've got the right level of oversight and assurance within our system. That makes sense.
Okay. So Kay, then Cecilia.
I just wanted to respond to what Rhiannon was saying there. In fact, with children and young people, the no wrong door approach is continuing to be very challenging, and there's been considerable resistance in some areas to it. So it's not, I'm not sure that there's things to be learned in looking at how it's going with children and young people, but it is a challenge there as well.
I'm just wondering how this overlaps with the right person, right place police programme. I didn't know. There seems to be an overlap with that programme, or am I?
There is, yeah, there certainly is. This was brought up a number of times by staff and teams that we spoke to. It's making sure that we're not misaligning as well, because there's obviously the RCRP steering group and the conversation that happened there. There's this work going on. Matthew said it is a good point. I think this is about a particular cohort of people, and we've noted that in the NHSE conversations, and there is a tendency naturally to drift into a wider conversation about a bigger cohort, about ways of working. But the next step will feature data, so digging into data a bit more, looking at electronic health records as well, so looking at particular case studies. Because it's been acknowledged that this piece of work so far is based on the feedback received from staff and looking at policy. So we need to back that up and sort of quantify it a bit more and consolidate it with more to give more of a rounded picture.
Again, my question is only because obviously the police will have data on and this seems to be focusing on persons who are most likely to be in crisis or experience crisis. I thought that's what that program was in.
But it's interesting, this cohort of people are often the ones that won't engage with services for a whole variety of reasons. Difficult to engage with services, that won't contact crisis services. Their friends and family will often contact crisis services on their behalf. It's a complicated picture, and it's not an easy thing to sort of paint a picture of. So I think for us as a system to be assured that we're doing everything we can and services are robust enough so we don't have a catastrophe like happened in Nottingham last year. It's not something we can do overnight. This piece will go on across the coming months, and it'll become richer in its information.
I think your reference, Mark, to the Nottingham incident last year really points out the complexity, doesn't it, and around service provision for people with mental health needs. I wonder if what we need to do is to come back to the board at some point in the new year with the variety of things that we're doing around mental health, because I think it's a really complex agenda, and I think there are lots of things being conflated with this piece of work that you're doing, because I think we don't all understand how it all fits together. So I wonder if that's the ask, and it might be through Matthew that ask is done with you working with the others to just paint out the landscape for us.
Yeah, we can certainly do that. I think everybody would welcome the opportunity to do that, and indeed we can do that on behalf of the Mental Health Delivery Board in the system.
Yeah,
so I think that's a great thing to do. And I draw our attention back to this is a sort of specific piece of governance that we need to have in place.
It was just to welcome that and to say let's make sure it is genuinely a system piece of work, because there is a whole system piece around the responsibilities around mental health, isn't there? So let's make sure it's genuinely helping a piece that understand that.
Did I see your hand? No. Okay. Patricia?
I just wanted to say, this is not criticism of anybody, but I think we need to be really careful about the language that we use when we talk about our communities, because we've heard a lot over the years, this group don't engage with us, this group don't engage with us, that group don't, and actually the reality is we're not creating the right space, we're not understanding their needs in order to get them to engage with us. So I don't want us to go in.
We have to engage with them.
Yeah, and I don't think this conversation should end with us thinking we've got a difficult group of people that don't engage with us or refuse to engage with us. We're quite often not creating the right environment for them to be able to do that. So some deeper understanding of what that requires across the whole range of services is how we're going to improve the way that people communicate with health and care, and not always think that the issue is the community doesn't want to engage with us, that group of clients don't want to engage with us. It's because the service is set up for Mr. Average, and if you're not Mr. Average, it can't handle what you need, and we need to do better in that space.
Yeah, and I guess what I took from what Mark was saying is that particularly for this cohort of people, they actually don't have the capacity to engage. So something else.
But that's our job.
Yeah, that something else needs to be put in place to make sure that can happen.
If you read the Nottingham case in detail and listen to the family,
right.
there was a lot
Absolutely.
that could have been done that wasn't done. It wasn't about the fact that that gentleman did not want to engage.
Yeah. Okay, all right. Well, thank you very much. You can see it's sparking lots of thoughts and discussions. So
It's a really mental health as a whole is a really complicated piece.
It is
so many different moving parts, and it's not just about health services. So I think coming back at a later date with more detail on that complicated picture is
that'll be really helpful. Thank you very much. Thank you both for coming. Right, so then that takes us to the Dorset ICS engagement plans to support the national programme. And I know Kirsty's been here anyway, but she's supporting this, isn't she? And Dawn, you're going to lead us on that?
I'll lead us into it and then Kirsty take you the table. So Patricia referenced in the Chief Executive update the 10-year Health of the Nation plan. And so Kirsty's just going to take us through the current approach that we're taking across Dorset and how that links to the broader Southwest. And then it'd be interesting to get the board's view on what else and what more the board would like to do to into this. So Kirsty, to you, thanks.
Thanks, Dawn. So we're taking a really broad approach to be able to support this and really make sure that Dorset voices are heard in the engagement exercise. So we're using our collective assets across our entire system, community and voluntary sector, with all of the networks that we've got, because we've got really strong links and relationships into those communities. And actually, that's where the engagement needs to happen with all of the groups that we've already got those relationships with. So we're using our collective channels, our collective assets and resources to encourage as many people, communities, staff, groups that we work with to be able to input and have their say. We're also going to be using our population health data so that we can do specific workshops with groups that we know facing more inequalities in Dorset, and particularly where Dorset might be an outlier in particular categories. We're taking that as a Southwest approach, so we're sharing that across our region. So where we know we've got communities that are similar, one of us will do that piece of work so that others can then focus on more bespoke areas. So I've mentioned a few in the report that we're doing. We're also sharing the rich data and insights we've already got. So we've had lots of conversations through our sort of listening exercises, through our 100 conversations, all of the work that we've collectively been doing in speaking to, hearing from and listening to our communities. And actually, it's quite pleasing in the plan. Most of what our residents are saying is what's going to be in the plan. So we want to take an approach where we're not asking them the same question that they've already answered. So we just want to carry on those conversations and actually share all of those insights with the national team. And the other point I wanted to make was that we've actually been involved in designing this national engagement exercise. So they recognise actually the quality of the engagement leads that we've got across our system and invited them to take part to actually shape so that it really then spoke to residents' communities on a level that they would then be able to be involved.
Okay, so one of the things we discussed right at the beginning under another item was whether or not we should have a system response to the 10-year plan consultation. So perhaps we can discuss that as part of this discussion now. So let's go for the discussion. Questions? Any questions or comments, Forbes?
So, no, just your last question. I think we should. You know, we can't complain if we're not prepared to engage in the consultation. I'm certainly encouraging GP colleagues to do it. And I think in the lines, we will send something in. Certainly, the national meeting I was at just before the launch of this, they said they were very, very keen to make this a meaningful consultation. So, how do they criticise the outcome? Give my thoughts now.
So I know it's kind
of, don't criticise the outcome, but you know.
I know it's kind of putting you on the spot, Kirsty, but I don't know if you've got any thoughts around how we do that, or you, Dawn, around how we collate a system-wide response to this.
So other we've got quite a while to be able to respond. So other Southwest systems are running like a session with the board to then put a collective response together. So we can absolutely look to do the same as our Southwest colleagues. And I'd sort of encourage any other networks or groups that you're involved with to maybe do collective responses back from those too. So internally, we're doing that with our staff network. So each network being able to give a response back on behalf of the kind of groups that they represent.
And what we might want to do is collate some themes of kind of key messages that we want to feature in that. And we talked quite a lot today, haven't we, about the prevention agenda, etc. So we might want to make sure that they feature in our responses. I think I saw Cecilia's hand, and I thought I saw somebody else, but maybe not. Cecilia.
I mean, I like the tone. I like the way that this is being put out to people. I think it looks really engaging, and I think for those who actually have access to digital media, I think we're going. Hopefully, we'll get a good response, and I think we take it very seriously because the way you've described. My question is simply for those that don't do the digital thing. Are we planning? Again, I wasn't sure what was the plan for those individuals. You certainly collated voices from the past. Things might have changed for those individuals. Again, I don't know. I didn't read into here. Maybe I've missed it somewhere. What plans for those individuals?
Yeah, we've asked the same question back to the national team about how else are you going to gather views, not just relying on that digital platform. So we're going to be doing the focus groups and specific workshops with cohorts of our community. So there'll be face-to-face events. We're also using every opportunity where we're going along to wellbeing events over the winter and tying it into all of the other plans that we're doing. Health Inequalities Conference, for example, there'll be a stand there where we'll be asking people for their views and being able to get people when we're with them to be able to respond, and we can help them do that on devices.
I was going to say, and again, to a point that Nick made earlier on, if there's a way that we can use digital in order to enable that, I mean, voice capturing of things, AI tools that can now really easily translate what someone said into somebody typing it.
Yeah.
And if I could also encourage you to call on board members to support those events as well, because that's one way that we can do that. Lisa.
I really like when we go out and ask people for their views, but I wonder what we're doing just to contextualise this and manage expectations, because what people want and what they need are often very different things. What people need and what we can provide are often very different things. How we prioritise what comes back. So I'm just interested in really the messaging around the ask, so that we are not setting ourselves up to be some kind of Santa Claus, and this isn't a letter to Santa that he's gonna that, you know, you're gonna wake up on Christmas morning and you're gonna have all this big stuff, because it's not going to be like that. So there's just a little niggle, a little risk that if we don't communicate that bit as well.
Yeah, I think in the narrative that we're using and in all the materials, it's clear it's the national government's plan, not our local plans that it will be directly informing. But what we have asked the national team and what we're trying to do as a Southwest is gather that data so that we can actually have it for Dorset and for the Southwest. Because at the moment it's all just feeding into like a big national machine. So actually the work that we're going to be doing locally on the ground, we're going to be able to try and capture those so that we could have a look at them and actually see how that can inform our next iteration of the joint forward plan, etc.
I take your point, absolutely. There will be a cohort of people who are at that end of things, but actually, I think we've got some good language here and a really good national message. And I think you're right. Let's keep it practical. You're always going to have to sift out that end of things, but let's manage expectations that have done.
There are methodologies, aren't there, to come up with a decision. Okay. So do you need anything more from us now then?
No, I don't think so. No, we'll just I'll work with the corporate office to look at putting a session in so we can do a collective board.
Perfect. Yeah, and also, as I said, just think about how you involve board members as well, because I think we'll be happy to support on those engagement events. Okay, so we don't have any items for consent. The IPR, the Integrated Performance Report, we've kind of picked up when we did the escalation reports. I don't know if there was anything else at all, Dean, that you wanted to pick up from that. I think we haven't covered.
It's in the narrative that's in the report. So
yeah,
I mean, there's some minor updates, but the main messages haven't changed from the report. Obviously, things move on, numbers slightly change, but the main message is the same.
So when we do the review meeting, I'd like us to think about the IPR, because this was the second time we've done it this way, wasn't it? So I'm interested in feedback as to whether or not we're approaching it right, whether or not it's working for individuals. So let's come back to that. We didn't have any questions from the public, so no questions there. Any other business? Patricia, I know you've got one, but if I start with the screen actually, so Siobhan and Kay and I don't know who else that's on there.
Charlie and Louise.
No, Kay?
No.
Thank you, Siobhan.
It's Charlie Green.
Oh, Charlie.
Yeah.
Charlie.
And Louise.
No questions, thank you.
Okay, and then is the other one Louise?
Yeah.
Yeah, that's fine. Louise?
No questions, thank you.
Thank you very much. And then let's come around the table. So, no. Andrew?
No questions. Thank you.
No. I know you have, so I'll come back to you, Patricia. Matt?
Are we able to begin part 2 earlier? Is my only question.
We probably can. Let me come back to that afterwards when we review the meeting.
Continue the conversation here. It's all down to you, Matthew.
Do you want anything? No, Rhiannon? You don't understand? Anybody? No? Patricia, do you want me to cover it? Yeah. Right. So we've had. I guess this the ICB teams.
Yeah.
Well, so we've had two ICB teams that were up for awards, and I assume won them, or yeah. One is the pharmacy team.
And Paul's got the detail.
Who? Paul's got the detail. Okay. And then the other one was the Nursing Times work on hydration, which of course we had presented here at some point. So that's pretty amazing.
It won the Nursing Times National
that's great,
Infection Control, so it's fantastic.
Yeah. And I think it'd be lovely to have an update on that at some point in terms of where that data's got to and what's happening. Because it's one of those things I always quote.
That face is you didn't tell me you were going to say that before this meeting.
No, it's only there's 2 for the prescribing team, and I can only remember one of them, and I'm racking my brain to try and remember what the second one was.
Well, you have to go for it now. So you want to say?
So the
one that you can remember anyway.
So they did it was basically check your cupboards before you order campaign at the end of the last financial year that went out to all of our patients.
So that people aren't ordering things that they've already got.
Yeah, so it moves away from the automatic knee jerk, either from community pharmacy or from patients to order every month the same things when they've probably got 40 inhalers sitting in a drawer, as most practitioners who've done home visits will have seen. Yeah. And it saved a significant amount of money in a very short space of time. And there's evidence. Well, there's evidence that would suggest that has produced a continued behaviour within our system, which is really helpful. So they've been shortlisted for the HSJ awards for that.
Great. Excellent. So if everybody's okay with it, might invite them to the next
that'll be really
business board meeting to join us for lunch, and then you've got a chance to talk to them about the work they've been doing.
And they can talk about the second one that they've also been doing.
I think we might do that
last year, didn't we? It's definitely. Let's do that. Let's invite them and also the hydration award winners in. So we'll do that for lunch. So key messages. Shall I turn to?
Hopefully I can.
I'm sure.
I think so.
I've got you.
Stop me if I say
and I've got some.
So the need to be more ambitious around how we're defining and tracking productivity, how we involve the wider system, the need to look at the prevention and out of hospital work and how to connect this with improving productivity.
In terms of the BAF, further work to understand the use of the BAF and the need to focus on the control and assurance agenda. To build on the response to the Darcy report, which will be the basis for the current 10-year Health of the Nation plan work. Positive workshop with system colleagues on medium-term plan with consensus over the next 3 years to deliver what's needed. Recognition of the integrated neighbourhood teams as a key transformation programme of work and the need to accelerate local conversations. So some big pieces of work to include whilst managing the financial landscape, and the system needs to be braver and safe. In terms of the escalation reports, a number of items were already covered in the meeting, so I've got a couple. Better forecasting to enable more effective mitigation of risks earlier, and then the impactful cardiovascular presentation at the Strategic Objectives Committee, particularly in relation to the focus on outcomes, and then to bring back the main 3 programmes. I think CBD, frailty and floor to respiratory, to a future board meeting. Board approved the committee terms of reference, noting the revised exec membership, and to revisit the provider representation on the committees. Winter plan, recognising the continued challenges around no criteria to reside and the need to deliver the plan by this winter, recognising there wouldn't be any financial flexibility over the winter. The need to front end with emission prevention, need to bring the board up to speed on Newton, and to consider how we step up the risk appetite and risk sharing ahead of escalation and looking at potentially through senior leadership discussions. And then congratulations to Kirsty and the comms team for their work undertaken. Noted the good progress for the primary care access recovery plan, the proposed approach in response to the CQC Dorset ICS pilot assessment, including the oversight and assurance role of the quality committee, and then noting the development of the action plan and the progress that will be monitored through the quality committee in terms of the intensive and certain community mental health review. Coming back to a future board with the mental health services provision landscape and the need for us to create the right environment to enable people to engage healthcare. Dorset ICS engagement plans. Apologies, I missed up the action from the corporate office. Action, didn't quite hear it. I think Kirsty mentioned there was an action.
Yeah, to hold a session for the board.
Oh, right, yes, yeah, I think you've covered that.
Yeah. And then finally, congratulations to the pharmacy team. Check your cupboards before you order, and the other one, and the nursing times work on hydration.
Such as medication reviews.
And we'll invite them to the next business meeting for lunch to talk about what they're doing.
The only thing I mentioned that was the cost of medications.
Yes.
Bring that work back forward as well.
Yeah. And then the only other thing I had was the breadth of the work that is actually going on that was conveyed in the CEO's report. But yeah, we've got anything else?
Can I have one more? And it's only because we've mentioned it twice, but really fleeting, but I think it really is important, which is the parity around mental health and physical health, because Dean mentioned it as part of the winter plan. And I think it's a really good message to say the winter plan isn't just about physical health, it's about mental health. So I think if we could pop that into the winter plan, that would be really helpful.
Great, thank you. Sorry. All right. Yes. Yeah. So, and I assume everybody around the board has had an invite, have they? So we have got the Health Inequalities Conference happening next week, and of course that's one of the themes that's come out today as well, isn't it? In a number of discussions that we've had. So, if we can just gently remind you to prioritise it,
bring as many of your notes as you can.
Absolutely, and attend that next week. That'll be great, because I think it gives us an opportunity to really focus on this agenda, doesn't it? So we'll do that. And then the only other thing then is review of the meeting. I haven't forgotten your question, Matthew. I'll come to that after we review the meeting. How has it worked or not, as the case may be? Papers, and in particular the IPR and the committee escalation reports. I'm keen to get some comments on that. That'll be between you and lunch. So, Lisa.
I think with the integrated performance report, there's still some work to do from our perspective, but I think we reflect that that discussion in the committees, and we do now have a time booked to sit around the table with the three chairs and have that conversation about just what we want. Finally, we got that meeting in the diary. So I think that will improve as the IPR start to work better for the committees. It will by default work better for the board.
I guess the PPT report stood out. I know it's right or wrong because Dean added more to it. But if we're going to take the IPR here as to note, or kind of wherever it sits in the agenda, then maybe we want a bit more of a fuller IPR bit in quality and where else would it go? Because finance people. Yeah. So because they're not consistent this month, the escalation reports, and either the PPT needs to come back down a level or the others come up, whichever, but it's consistency.
Let's think about that outside of here then.
Can I just, I mean, I have to say, because with the IPR, I mean, just this, I don't know how other ICBs do it, but my slight concern is that this is a public meeting, and actually it is quite good for us to have quite an in-depth discussion around our integrated performance, including the money. And I'm slightly concerned that if you reflect on the meeting, we probably, you know, there's an opportunity for us to have more of a discussion probably on the integrated performance. So I just would probably ask that we reflect a little bit on that.
It's partly why I'm asking, Siobhan, because certainly with my provider board is a really key part of what we do.
Yeah, exactly. We have a really long conversation around the integrated performance, including the financial performance.
Yeah. But I don't know what others think.
It's a really difficult balance, isn't it? Because we've got other partners around the table who don't want to be sat here for 6 hours if all we're going to talk about is NHS business and not the wider partnership. But we've got to find a way of covering the integrated performance issues off in a way that's valuable to everyone.
So shall we have a think?
Yeah, I was just going to say that, you know, maybe one of the opportunities, because we want to make it a system performance report, don't we? And I know that's not that easy, but you know, how we do that in a whole system way might be part of the interesting intellectual challenge for us.
I agree with Patricia. It's hard because the other thing, we don't want to replicate the work of the committee.
Yeah, absolutely.
Conscious that Siobhan was talking about reflecting and I would jump to solutions, but actually having some of the execs talk to some of the escalation reports as well as the NEDs might bring some of that IPR flavour out if we get the flow right through the escalation reports, because NEDs have the chairs have a view, but actually the chief officers can bring more of that richness and
Yeah, we did it for the people one, didn't we?
Yeah.
Okay, so let's think about it. Do you think there's? We don't want to expand it for the sake of expanding it, but I think there is also something about, you know, this is the public part of the meeting, isn't it, where the public are in attendance, and they will want to think that we are actually looking at the things that are important to them. And I don't know if we've kind of got that balance right, so let's come back to that.
Well, sorry, what's your view, Gillian? Because I mean, Patricia's point is this sort of. Well, I mean, that's the point. I think we have to look at NHS business to board and regulators say, well, how's your board cited on this?
Yeah, I mean, I expect to come to these board meetings and for a bulk of the time to be about the NHS system. I think it is helpful that we make those wider connections and we're starting to bring some of the metrics into the integrated performance report, because that's the space that we need to get into and where we've got the potential to do more. I don't think you have to make all of the conversation relevant to everybody in the room, because the board will then stop performing its function. So I think getting balance there is fine.
Yeah, it's the integration piece is the key. Part of that, isn't it?
Yeah,
so
recognising there's an integration, it's a bit like the conversation around the integrated neighbourhood teams. There's an integration that has to take place within the NHS as well as a wider integration.
Okay, all right. So by resolution, we shall exclude public. all one of you that are in the room. So if I can ask you to leave us now, please. And then I think we had 45 minutes for lunch. I'm going to suggest that we take half an hour. So if we can start back at 5:02, does that work? Or do we want to round it after 2 o'clock? Right, so 2 o'clock. Matthew, does that work for you? Okay, so let's resume at 2 o'clock then for the. Thank you all very much.